Okay, good afternoon, everyone, or good day, depending on where we are. Um, this is the Concept Academy. My name is Dr. Babawale. I think this is the first time I'm meeting most of us. Um, Dr. Festus has been with us for the past couple of months, and I am sure we'll have enjoyed staying with him. I really want to encourage us to make sure that we pay attention to all those things that you have said, because trust me, you'll find them very, very relevant to your exam. Pay attention to what it says you should pay attention to, major on the major and minor on the minor. The step 2 exam is very easy. You just need to look at it in a conceptual manner. You need to make sure that you are you understand what you are reading. You're not just reading first stage because of reading sake. You understand what you are reading. You are paying attention to the key details it was emphasizing, and you are calm. And of course, you pray to God. Everything is going to be very, very easy for us in Jesus' name. Definitely before we go for our exam, it's possible maybe we just have to have some talks. Probably we are going to organize a section like that just to emphasize some of the key exam taking strategies that we might need to know before we go for our step 2. So God is going to help us. So today we are going to be talking about ethics, some part of ethics, patient safety, and the healthcare delivery. So before we start, I just want to mention that this part is actually important, and it's one of the part that many people find challenging. Even me myself, I still find it challenging, because it's not clinical. Most of us enjoy clinical stuff, but when it comes to all this, ethic, patient safety, whatever, we get down a little bit. But I just want to encourage us to just give it our best, because it's going to come out in the exam. If we like it or not, it's there. The ethics will constitute about 5 to 10% of your question, and also the patient safety, it's 5 to 10% on its own, sitting on its own, not mixed with ethics. So it's important, we try to pay so much attention and try to get the gist of what we are going to be discussing. Okay, so we start with the healthcare system delivery, starting with the healthcare insurance plan. So what does the word insurance plan mean? So the word insurance plan is just more like a way to subsidize treatment, like medical care delivery, to the citizen of a country. So, and the country we are talking about today is that of the US. So we need to know how their insurance plan are arranged. We need to understand the way they go about the treatment. I mean, the way they go about the payment for some of the treatment that they offer. So before we delve much into that, I want to show us a table that talks about the classification of the insurance. So please, can we hear me? Am I audible enough?
Yes, sir.
Okay. So we need to understand that it's broken down into the government funded insurance and the commercial insurance. The government funded insurance and the commercial insurance. So just from the name, government funded, it means that it is the government that is funding that insurance. While the commercial one, they are practically owned by some private companies. Maybe they could be individuals, they could be a group of employers or some private, company. So we are going to be breaking them down one by one. So what is a funding source for that of the government funded insurance? Majority of the money, um, they are funded by the the federal government, the state or the local government, but majority of the money comes from deductions as tax from people that have worked for the government. So the ideal thing is that if you have worked for the government for a minimum of like 10 years, so the deduction in form of the tax, is sufficient enough to register you under, the government funded insurance, which we are going to be looking at later. While for the commercial one, the money is coming from individuals, employer, or private company. For example, people that maybe go to some schools, some schools might offer insurance under like maybe employers or something. Or maybe you get a job, employers can also register you under the commercial plans because you are working for them. So schools is also under these ones too, and maybe some private jobs like that, but not from the government. So what is the eligibility criteria for the government funded insurance? So it depends. The commonest one is age. And what is this age factor we are talking about? They have to be more than 65. Once you are 65 and above, most of the time you are going to be qualified for this government funded insurance. Or maybe somebody is disabled, somebody is working for the military, even though they are not up to 65, they can also qualify for some of these government funded insurance that we are going to mention later. So aside the age, there's something that is also very important, and that is your status in the country. You must be either a permanent, a legal permanent resident, or you are a citizen. So you're a citizen or you're a legal PR and you are 65 and above, you can qualify for the government funded insurance. Or maybe somebody is disabled, somebody is having they are under the military, blah blah, they can fall under the government funded. Why normal individuals like us now, normal people that just work for some company, they can get registered under the commercial insurance. That is why more than 65% of people in the US fall under the commercial insurance. So, what is the cost to these individuals? So, anybody under the government funded insurance, they usually pay some lower out of pocket cost. So, meaning that the money that they are going to pay out of their own pocket is going to be smaller compared to the money that the insurance company are going to pay the healthcare providers or the doctors. So, why for the commercial insurance, the money that they pay, that the receivers, the individuals pay, is actually more, compared to the government funding. Of course, if government is funding something, you expect the government to pay most of it. So, but for the commercial insurance, they pay higher premium. So we are going to talk about these terminologies later. So premium is just more like the certain amount of money you pay to keep an insurance going. That is premium, While deductibles are more like a certain amount you pay to kick in the insurance. Let me come again. The premium is what you pay maybe every month to keep the insurance going. You are not using healthcare services, you are using healthcare services, you need to pay premium just to make sure that it is going. That is premium. Because once you stop paying the premium, it automatically cancels. What about the deductibles? So deductible will be like, for example, they might say that, okay, maybe somebody goes to see a doctor now, and the doctor writes the cost of the healthcare service that was delivered to the person to be $1,000. So that is pay for service. That is the amount you are supposed to pay for that episode that the doctor, sees, for that service that the doctor delivered on seeing you. That is what you are supposed to pay, $1,000. So you are going to have an agreement with your insurance company with respect to deductibles, co-payment, and co-insurance. So what am I talking about with respect to deductibles? They will tell you that, okay, fine, before we can start paying, offering you some money for insurance, you have to make sure that you meet a certain quota of this insurance stuff. They could say that before we can start saying that, okay, we want to be paying insurance for you, or paying part of your healthcare service, you must make sure that you have paid a minimum of like 100. So most of the time they charge it, this deductible, they charge it annually. So once you have paid 100, bam, so your insurance now starts kicking in. So they can now look at the amount you are owing. Oh, so you have gotten a bill of 1,000. let us now look into how we can now pay this 1,000 for you. So that is deductible. But most of the time, they will also remove that deductible from what you are owing. So in this case now, it's now going to be 900 that is remaining for that person to offset, to pay. So the co-payment now comes in. So co-payment is a certain amount of the money that is remaining that you must always pay. So it could be like $20, depending on the service. It could be like, maybe if you see a doctor, you have to pay like $20. If you do a lab test, you have to pay co-payment of $10. If you maybe use any machine, you have to pay $50. So depending on the service, there's a specified amount of money you have to pay as co-payment. So in this case now that this person is already owing $900, the co-payment may be that pay $50 because you just came to the doctor had some conversation with you, and maybe the cost of that is 1,000, but you have already paid deductible of 100. It remains 900. There's a need to make co-payment of 50, so you pay 50. They will remove the 50 from the 900, remaining 850. Then the last part is now the co-insurance. So that is a specified percentage of the remaining money that you must also pay. So that one is in percentage. The co-insurance is in percentage, but the co-pay is a fixed amount depending on the service that was delivered. So the co-insurance might be that you have to pay 15% of the money, 20% of the money. Then once you pay that 20% of the money, the insurance company will take care of the rest. Please, do you understand what I've explained? Anybody understand what I've explained, or there's any confusion? Is there any confusion? Anybody? I cannot see our what's it called reaction, so I have to minimize it. But do we get what I'm saying?
Not fully.
Hello?
No, not fully.
Okay. Okay. So so what I was just saying is that we've talked about the premium. Premium is a certain money you need to pay to keep the insurance going, so that you can say that I have insurance with this company. I have insurance with these particular people. You have to be paying premium. So most of the time, if you are working for a company, they will be removing that premium from your salary. They will be removing it every month. This is the amount that will go to premium. So when you now go to see a doctor, now that premium will be removed. Regardless of if you go to see a doctor or you do not go to see a doctor, they will always remove the premium. Now, when you now eventually go to see a doctor, and I don't know, okay, let's just say that the person went there to complain of malaria, and let's the cost of the services of seeing that particular doctor at that particular time, the cost incurred is like $1,000. $1,000, that's what you are supposed to pay. Now there's something called deductible. That is the amount you have to pay from your pocket. It is an out-of-pocket payment. That is the amount you have to pay from your pocket before your insurance can start kicking in. Do you understand that, Dr. Paulette? Do you get that? Hello?
Yes,
Yeah.
yes.
So that's the amount of
That's
money
one.
you need to pay for your insurance to start kicking in. So it could be, depending on your arrangement with the insurance company, it could be $100. So usually it's yearly. They charge deductible yearly. So once you pay the 100, then anything else, they will now start, you and the insurance company will now start negotiating on how to take care of the rest. So, but if you don't pay that deductible, they will never, kick in. They will never start helping you. So even if it's $50 you pay deductible, they will still not do anything. You have to make it complete 100, before they will now start looking at what's the remaining. So if you have paid the 100, they remove the 100 from the 1,000, it's going to remain 900. So 900 is the money left for you to now, pay. But the thing is, the insurance company will not pay the entire 900 for you. Another thing will start coming in again, and that brings about the concept of the co-pay and the co-insurance. The co-insurance is not listed here, but I'm just going to mention it in case you see it in your exam. So co-pay or co-payment and co-insurance. Now, co-payment is a certain amount, a fixed amount you have to pay depending on the service. You go to see the doctor, 20. You go to see, that's the money you have to pay out of pocket, constant. You have insurance, you don't have insurance. you have to pay that 20. You go to say a nurse 30, you use lab 50, depending, you know. So if because you've seen this doctor now, everything is 100, but the co-payment, you know, from that 100, from that 1,000 is maybe $20. You have to pay that $20 yourself out of your own pocket. You have to pay it. They will remove it from what is remaining. So we have paid 20 out of the 900. It remains $880, right? Then the last one is now going to be your co-insurance. So co-insurance is certain amount of money, percentage of that money that's remaining that you have to pay. It is a percentage. It is not fixed like co-payment. It is a percentage. So it could be 10%. It could be 15%. So once you make that percent, so they will now say, okay, 10% of the 880, that one is $88. Pay your $88. We will now take care of the rest. That is it. Do you understand that, Dr. Paule? Do you get that?
Yes, but yes, I get it. My confusion now is this deductible. Are they done used individually, like differently, or they can
Yes,
be used all together?
it is individually. It is individually.
Okay.
So,
Okay.
you know, it is individually. It is not like it is individually for you as a person. That's what I mean. Oh. For you as a person, it is individual. So that is it. Once you have met up with the deductible agreement you have with the insurance plan, that is all. You are done for that year. Because I said it is charged yearly. You are done for the year.
Yes.
So that is that. So now what are the examples of let me try to zoom in this so that we don't. So what are the examples for the government funded insurance? We have the Medicare, the Medicaid, which we commonly talk about. We are going to see it shortly. So they are under the government funded insurance. And we also have the commercial insurance plan. We are going to talk about some of them shortly. So let's move. And then so I have talked about the government funded one, which is the Medicare and the Medicaid. We are going to talk about it after this. So this is a commercial health insurance plan. So they fall under four categories. We have the health maintenance organization, we have the point of service plan, we have the preferred provider organization, and we have the exclusive provider organization. So the simple way I just want us to look at this is that if somebody wants to see maybe a specialist, sometimes they might need to go to a general practitioner. Maybe somebody thinks is having maybe normal headache. So of course the person wants to go to a GP first that this headache is worrying me. Oh. Maybe if the GP now reviews and say that bro, you are going to need advanced care. Maybe you are going to see a neurologist because this thing is looking like maybe you're having like subdural hematoma or something. You have to go and see a specialist. So sometimes it might work like that, that you need to go through a primary care provider first before you get, referred for a specialist care. So that is to establish what the primary care provider means and specialist care. There's something we call the out of network care. Now, what they are trying to say here is that, you see, this insurance plan, most of them, they have a network of doctors that they use. So that means that if you subscribe to any of these commercial health insurance plan, you are going to be seen by a network of doctors, nurses, pharmacists, physiotherapists. You cannot go, sorry about this, so sorry about that. Um, you cannot go outside. Please, just 1 minute, 1 minute. So, I'm so sorry about that. So, network of doctors that they usually use. But sometimes, some patients might actually prefer to see some certain doctors. So that is going to be extra money, coming out from your pocket. Now, let us look at them one by one and try to understand what the plan looks like. So the first one is the Health Maintenance Organization, the HMO, the HMO. So the HMO and the point of service plan, the POS, the HMO and the POS, what is common to both of them? You have to go through a primary care provider. So once you are registered under the HMO or you are registered under the POS, you have to make sure that you go to a primary care provider first, you know. And the difference between the HMO and the point of service is that for the HMO, if you want to see a doctor that is outside the network of doctor that is offered by this HMO, you have to, your insurance does not cover it, except it's a case of emergency. So you cannot say that I just want to see a doctor that is near my house. No, the insurance does not cover that unless it is a situation of an emergency. But what about the point of service? Even though you have to see a primary care provider first, if you can decide to get out of network care, you can decide to see, somebody that is you prefer. There's flexibility. You can decide to see a doctor that you prefer. Your insurance covers it, but it's just that the bulk of the money that you are going to be paying out of your pocket is going to be a lot. And don't forget what I've talked about when I was mentioning the out-of-pocket cost. I mentioned something like the co-payment, the co-insurance, and the deductibles. They are all part of the out-of-pocket payment. So if you want to see a specialist with under this HMO and POS, you have to go through your primary care provider. That's the one that's going to refer you to the specialist. So don't forget the difference between the HMO and the POS. The difference is just that for POS, you have flexibility of seeing out of network doctor. Why for HMO, you don't have that flexibility unless it is an emergency. But both of them, you must always require to go through a primary care provider. So moving on to the next one, which is a preferred provider organization, the PPO, and the exclusive provider organization. So me, I see it as if preferred provider organization is better than the exclusive provider organization. What is common to both of them? These ones, you don't need to go through any primary care provider. You can decide to jump to a specialist directly. You don't need any referral. They will never ask you for a referral letter. You can jump to see a specialist. But what's now the difference between the PPO and the EPO? So for the PPO, because we said that it's better, it means that I can decide to see a doctor that is near my house. I can decide to see a doctor that is out of the network. It's just that I know that I have to pay more. Yes, I can pay more. So this one is for the rich. If you know you have the money, go for the PPO. You can see any doctor anywhere. But for the exclusive provider organization, you don't need to see a primary care provider, fine. But you cannot see a doctor that's out of the network, except it is an emergency. So, and of course, for both of them, because you don't need to go through a primary care provider, there's no need for referral when you want to see a specialist. Do we understand this? Does it make sense to us?
Yes.
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 Yes. Yes.
Okay. So, let us go over the way they now make the payment. So I'm just going to be simplifying all these things for us. We don't need, to know all the grammar. Just understand what they mean. That is what you are going to be using in your exam. You don't need to be cramming what is there. So I have a statement there that BCG is fixed to your harm. So anywhere we see anything B, which is bundled payment, C for capitation, and G for global payment, we know that the amount you are paying is fixed. So the bundled payment is just the way they want to pay for this healthcare service that the patient or the user has incurred. What they do is that they pay a specific amount regardless of the regardless of the normal cost that the person is supposed to pay. Maybe everything the person is supposed to pay is like 20 plus 10 plus 10 plus 10, everything amounting to 100. They will not work with that. There's an agreement the insurance organization have with the healthcare providers or the hospitals. There's an agreement that, okay, I don't want to know how much they spend. I don't want to know how much you guys incurred in delivering the healthcare service to our clients, but we are going to be giving you a certain amount. And when they say that we are going to be giving you a bundle of money, a certain amount of money, you will now share that money among the departments that saw that patient. So they will share it to nephro, they will give renal their own part, give emergency its own part, give physiotherapy its own part. That's the statement you are looking out for. There's going to be a share of the amount divided across all the providers and the facilities involved. Once you see that, go and pick bundle. You don't have to be a genius. Just go and pick bundle payment. You are going to be correct. I can assure you. Then the next one is capitation. Capitation is just like it's also similar to the bundle payment. It's just that you are not, paying money to be shared across. No, you are just, setting. You are just giving. You are paying a certain amount of money per person per time. So usually they pay this capitation monthly. So per patient per month you are paying $100. They are not sharing anything. You are just giving it to the what's it called to the healthcare providers per month. You are for this head per head. This is a certain amount of money I'm going to be paying. That is capitation. So don't forget about that. And it has to be regardless of if they use healthcare services or they did not use. Don't forget for bundle they must have used because it's per service. So this episode that they saw this patient, this is what was incurred. They'll make the bundle payment. But for capitation, if the patient use the patient doesn't use they have to be paying that money per month. So $100 per patient per month to the hospital, regardless of if they used or they did not use. That is capitation. So let's move to global payment. So global payment is just very similar to bundle. So it's just like money that you pay the hospital or the health service provider for a population of patients that receive treatment. That is global payment. So it's not something that occurs frequently. So once maybe a population of patients, I don't know, maybe anything happened, they are just seeing like a mass of patients at once. They just make that global payment for all of them. So fee for service is just like you go to see a doctor now, the amount of money you are supposed to pay. Like when I was giving the scenario of the $1,000, that is a fee for service. So you go to a doctor, you go to any healthcare provider, the amount of money you are supposed to pay is the fee for service. So sometimes it can be discounted. They can say that, okay, even though your actual cost for this service that was delivered is 1,000, we are going to be giving you a discounted fee for service insurance. So pay 15% of 1,000. So, they'll calculate, or maybe they can just pay 10% of the 1,000, which is like 100. And they'll be like, okay, so, sorry, pay, no, they cannot say pay 10% of 1,000. They will say that we are removing 10% of 1,000. So from your money, we are giving you a discount of 10%. So you are supposed to pay 900. So it is 900 that you are now going to be working with. So your what's it called? Your deductible, you have to meet up the deductible. Maybe deductible is 100. You have paid your deductible, they remove it from the 900, remaining 100. They will now start looking at your co-payment to $20, they will remove it, and your co-insurance 15%, they will remove it. That is it. That is it. So let's move to the Medicare and the Medicaid. So now, the first thing I'm going to say here is that we need to know the body that's actually working with this Medicare and the Medicaid. The Medicare, the Medicaid. We have said that this is part of the hospital giving insurance, the one that is managed by the government. Sorry, I said hospital. By the government is the Medicare and the Medicaid. The government is the one in charge of the Medicare and the Medicaid. So, what is the administering body for the Medicare? So, Medicare is like the commonest one. That's one that is more common. So, Medicare, the administering body is the federal government. While for the Medicaid, it is both the federal and the state government. The Medicare is more like an insurance. The Medicaid is a aid. Medicaid, aid. You are assistance. You will see why it makes sense for us to call it assistance shortly. What is the eligibility for Medicare? Just like we said, you must be 65 or above. In addition to that, you must be a US citizen and what? And You must be, or you are a legal permanent resident, or this person is having a very disabling condition. Probably this person has ALS, cannot move the arm, cannot eat, cannot swallow, cannot do anything. Or the person is having end-stage renal disease that is undergoing dialysis, just like we have here. Dialysis, or the person has even received a transplant. So all this category of people, they can benefit under the Medicare. So people with disability or people with dialysis, they don't need to be actually be 65 before they can qualify for the Medicare, right? Why the Medicaid is actually for the people that are poor, for the masses that are very poor. So they usually say that people that earn below 133% of the federal poverty level, we don't need that fact. The question is going to spell it out to us that the person is poor and doesn't have any money. So, that is Medicaid. Once the person is very poor, they can, get registered under the Medicaid. And also some of the eligibility under the Medicare can also fall in a Medicaid. So we have talked about the copay and the co-deductible. We just pay small premium and co-payment, in both of them. We don't actually need that, and the B payment for the Medicare, of course, it comes from the trust fund. So that means that it comes from the money they have been removing from your salary when you have worked with the government for like minimum of 10 years. So that's a trust fund. So that is for the Medicare. For Medicaid, they don't pay anything. They don't pay anything for the premium. It's because they don't even have money in the first place. That's why they're under the Medicaid. So what is the coverage for the Medicare? So it comes in 4 parts. There's part A, there's part B, there's part C, and there's part D. So part A and B. Part A means hospital, let's say medical, let's call it hospital insurance. That's what they call it, hospital insurance. Part B is called medical insurance. Now, let me break it down. The simple way we can look at it. Part A is the person being housed. So if the person gets admitted in the hospital, he has to pay through Part A. If the person gets admitted in a nursing home, Part A. The person gets admitted for home hospice care, Part A. Anywhere, just rehabilitation facility, Part A. You are just admitted somewhere, Part A. Part B is medical. So maybe you go to see the doctor, outpatient, Part B. You go to the hospital, they do a lab test for you, Part B. They do eye examination, Part B. Medical B. Part D is for they now write drugs for you. That is Part D. That has to be covered. Part D is for prescription drugs. Now, Part C is good. But before you can get the benefit of Part C, you must be registered under a private insurance company that has been registered under Medicare. Let me take it again. There are some private insurance companies that get registered under Medicare. They have Medicare approval. So if you register with that kind of private insurance company, you have access to Medicare services. And that services is called an advantaged Medicare service. They call it Medicare Advantage. That's for Part C. Anybody that is registered for this Part C part, because you are registered for under a private insurance company that has, access to Medicare services, you get access to the Part C. And what is a Part C? You have access to both Part A and Part B, benefit, even including Part D. So you get access to, they will pay for your hospital admission, they will pay for your medical bills, they will pay for your prescription drugs, even vision care. If they do anything in the eye, they will also pay for it. So anybody with basic Medicare insurance, it's just only Part A and Part B that they usually cover most of the time. They don't cover for Part D, But if you have access to this Part C, you will get access to Part A coverage, Part B coverage, and Part D coverage. So Part C is actually good, but you must be able to pay in some way because you are going to a private company. While for Medicaid, it's just for people that don't have money. So it's a form of assistance which is organized by the federal government and the state government for anybody earning below a certain income, someone that is pregnant, a child, and so on and so forth. They can get registered under the Medicaid and they'll get some support. And these are the supports that they can have access to: dental care, glasses, medication, blah, blah. Don't worry about it. They really hacks all those things. So let us move on. Okay, I think we have one or two questions to please, I want us to try to understand, because that's what I usually try to encourage. You see, the USMLE is a concept-based exam. The USMLE is not hard. They just want you to go there and think. Once you are the type that you don't take time to process, the person will have problem. So always try to understand what they are talking about in the question. Once you can do that calmly, you have passed. Forget about it. You have passed. I can assure you. You do very well. Don't rush. It's not an exam of to go and be doing spanner level. Nobody is chasing anybody. Just go there, read the question, understand what they are talking about, and pick your answer. That is it. If you don't understand it, flag and come back to it. So let us look at question 1. Question 1 says, before starting a job at a law firm, a 33-year-old woman speaks to a representative about the healthcare insurance plan offered by the firm. The representative explains that treatment is provided by primary healthcare physician who focus on preventive care. Okay. So the representative explains that the treatment is provided by primary healthcare physician who focus on preventive care. Good. Patients require a referral by the primary care physician for specialist care inside the network. Treatment by healthcare providers outside the network is only covered in the case of an emergency. When the prospective employee asks how prices are negotiated between the healthcare insurance company and the healthcare providers, the physician explains that the healthcare providers get a fixed payment for each patient enrolled over a specific period of time, regardless of whether or not services are provided. This arrangement best describes which of the following healthcare payment model? Anybody? Is it pay, DM? Is it bundled?
Capitation.
It's
Capitation.
capitation.
That is capitation.
Capitation.
Now, that is very good because it said get a fixed payment for each patient enrolled over a specific period of time, regardless of if they use it or they don't use it. That's capitation until otherwise proven. Now, what do we think if we look at this question critically? Which type of commercial healthcare insurance plan is this person under? Looking at what it said.
HMO.
The what?
HMO.
HMO.
HMO. HMO, yeah.
HMO. You see, because they said they need to be referred by the primary care provider, and what the treatment by the healthcare provider outside the network is only covered in the case of an emergency. That is HMO until otherwise proven. Very simple. So moving on to the next one. So before starting a new job, is it not the same question? Okay, it's not a new question. It's a new question. Before starting a new job at a large healthcare organization, a 29-year-old physician speaks to a representative in the Human Resource Department regarding the healthcare payment model used by the organization. When the physician asks how prices are negotiated between the healthcare insurance company and the healthcare organization, the representative explains that the organization is compensated a fixed amount for each episode of care. The representative explains that the fixed amount is distributed amongst all the healthcare providers that provided care for the patient for that specific episode. These arrangements best describe which healthcare payment models. Anybody?
Bundle payment.
Bundled
That
payments.
is bundled payment.
Bundle payment.
Yes. So this one is a little bit tricky, but let's all look at it. A 29-year-old woman with hypothyroidism comes to a primary care physician for advice on a healthcare insurance plan. She works as a baker and owns a small bakery. The patient explains that she would like to have affordable monthly premiums, but would be willing to make additional payments to be able to see provider outside her network. The patient notes that she would be comfortable being referred to specialists by a primary care physician. Which of the following healthcare insurance plan would be the most appropriate? Anybody?
POS.
POS! Fantastic stuff. It is POS. Because they said what? They said this patient is willing to make additional payment to see providers outside our network. Okay, so that means that it can be PPO or can be POS. But they now further give us another information. They said she will be comfortable with being referred by a primary care physician. So that makes it POS. Very good job. Very good job. Okay, so moving on to palliative care. So what do we need to know? We don't need to cram all the statements that they are talking about here. Fine. It is an approach to improve the quality of life of patients experiencing life-threatening illness. Yes, please. I want to make a statement here. Don't mistake end of life care for palliative care. Don't make that mistake. They are different. Somebody might not be actively dying and the person would, get palliative care. Yeah. So it doesn't mean that if they say that go and give this patient palliative care, it means that the person is dying. No. Somebody can have ALS and the person was subjected to palliative care. The person is not dying. It's just that the person cannot do some certain things because someone that has ALS will not be able to, upper motor neuron, Dr. Vani stuff. I mean, Dr. Vani will have gone to town. We know what we are look out for when it comes to ALS. They can't do anything. So you have to be going to their room to be feeding them. You have to be pushing them all around. That is a form of palliative care. You just want to improve their quality of life. Of course, they will be sitting in a position for a long time. They can have pain. So you want to give them what's it called? Analgesics, right? They could be because of the fact that they are all alone, they're not doing anything, they can be having depression, they can be anxious. So you want to give anxiolytics, you want to give antidepressants. In that way, you are offering palliative care to improve the quality of the life of the person. But if they tell you that somebody has less than 6 months to live, that's a different thing entirely. So that's going to be end of life hospice care. Don't make that mistake. They are two different stuff. So what are the symptoms you want to address palliative care? The common one that should always come to you with respect to the USMLE that they always test is pain. Pain should be number one thing in your mind. Looking at the question, just look at it. Is this patient having pain or anything? Once you are saying that there's pain there, please go and manage the pain. If the person is having breathing problems, is this person having difficulty in breathing? Let us take care of the dyspnea. If the person is depressed, manage the depression. Patient anxious, manage the anxiety. This is not the time to be offering life prolonging measures that you are saying that you are doing screening for diabetes, you are doing screening for hypertension, you are placing on aspirin because you want to prevent stroke. No. So you just want to make the person comfortable. Very, very important. That's the goal of palliative care. So they go through some stage. And what are the teams, involved in palliative care? The clinicians, the nurses, the social workers, the chaplains, all religious people, the pastors, the imams, they come, they do prayer for them, So those are the people that are involved in palliative care. And the doctor that we see, we have a care plan that, so this is what this person should be doing, be taking this person regularly for physiotherapy. These are the kind of food that the person should be eating. Liquid diet, because this person cannot swallow. ALS, they cannot swallow. Liquid diet, don't be giving amala, don't be giving eba, just be giving pap. They have a care plan. By this time, take him out for physiotherapy, all those kind of things. So you are monitoring the symptoms every now and then, and if there's any deterioration or any deviation from normal state, you change the care plan. So you can now be categorizing the person into stages, right? So if the person is stable, person is doing fine, no problem, just continue what you are doing. Give your anxiolytics, give your antidepressants, give your painkillers. If the person is having dyspnea, give your morphine or Opioid. Some people will be asking me now that if somebody that is having this now, we are now giving him morphine, to now cause respiratory depression and the person will die. So the thing is, most of the dyspnea that they're having usually comes in form of breathlessness. They'll be having tachypnea. So you can, use the side effect to treat that breathlessness, because you know that if you give somebody opioid, it's going to cause some form of respiratory depression. So that can reduce the breathlessness and make them comfortable. So you are using, the side effect as a therapeutic, measure or a therapeutic effect. So that's it. So initially they can be stable. Just continue your care plan. So maybe they could develop an infection or something and they become unstable. You start noticing that the symptoms become worse, or you are just seeing some new things that you are not expecting. So you want to change your care plan accordingly. Then you also want to provide mental, emotional support and spiritual support for the patient as well as the family. So you try to organize people that will be, the religious people. If the person is a Christian, if the person is a Muslim, the what's it called, the imam and the pastor, they'll come around to talk to them. The social workers are always there to also, help with social needs, provide emotional support and all those things. Then from the fact that they have new symptoms, they could also start deteriorating. So they are no longer tolerating food and all those things. You still continue your emotional support, your spiritual support. They could now become terminal now, in that they are now bedridden. You can at this stage you cannot even move them out of the bed. They have a loss of appetite, difficulty receiving treatment and all those things. So you just admit them to the hospital and continue the management until they finally die. So that's the bereavement stage. So you just call in spiritual support in the priest, the pastor, the rabbi. They just talk to them, talk to the family, reassure them, and that's it. So just like I had said earlier, if the prognosis of the patient is less than 6 months, or when life prolonging treatment is no longer beneficial to the patient, you have to register that person for end of life or hospice care. Very important. You know that there's no way you can prolong the life of this person, or this person is going to die in less than 6 months. Hospice care. Very important. So don't forget all the symptoms we have talked about. Palliative care, um, what's it called? Pain control, dyspnea, and physical symptoms, psychological symptoms that we have talked about, like what? Depression, anxiety. Some people might even be worried about their family fighting over the will. So you have to address that question well. Look at what they are talking about before you know the next line of management. I don't know. I think I have a question here. So let us look at this together. So this is a 78-year-old woman who is receiving home hospice care for end-stage metastatic colon cancer. Is examined at her daughter's request because of a 2-week history of progressive breathlessness. She reports that her mother has been bedridden for the past 3 months and started sleeping in an upright position in the last few days. 2 months ago, a percutaneous endoscopic gastrectomy tube was placed because the patient was unable to feed herself. For the past day, she refused to drink water or to be fed through the PEG tube. Medications include morphine, magnesium hydroxide, metoclopramide, Dexar. The patient still appears cachetic. The pulse is normal, respiratory rate is on 11, blood pressure is 110/75, the pulse is 96. The skin overlying the PEG catheter appears well perfused with no tenderness to palpation, no purulent discharge. The lungs are clear. The remainder of the examination shows no abnormality. Which of the following is the most appropriate next step in the management of this patient breathlessness? Anybody? What are we going to do?
Increase morphine use.
Increase morphine dosage. So as we go down, there's a part that we are going to talk about what we call double effect. So in as much as the fact that you are increasing this morphine dosage can kill the patient, it's still allowed. Make the patient comfortable. Even if the increase in the morphine will kill the patient eventually. Still give it. That's a double effect. So don't be shy. Don't be scared to pick, pain control. Most of the time, it will be the correct stuff. Pain control. Don't forget that. So,
In this case, sir, let me interrupt a little bit. The main purpose of the visit was for dyspnea, respiratory distress.
yes.
So you are not going to do anything towards that. You are just going to increase the morphine dose. There is no complaint of pain here, right?
Yeah, there's no complaint of pain. Just like I've mentioned before,
Mm-hmm.
if they're having breathlessness, you can use what's it called? The opioid to actually suppress the respiratory center so that they will not be having the breathlessness again. So I was saying that you are using the side effect of opioid to achieve some therapeutic control.
Mm-hmm.
Do you understand that?
And
So that is
yeah,
why the opioid will be the most appropriate treatment here. There's nothing we
even
can
though
do
mm-hmm.
again aside that. Some people talk about fanning and all those things, but the best thing is just increase the opioid medication. Even though some people might be scared to pick it, they'll be thinking that the patient will die. But
Mm-hmm.
no, you have to ensure that the quality of the life of the patient is better. The patient is actually comfortable. So you don't say that the patient will die. You will not now give morphine. The law allows it. Give the morphine. If it's going to make the patient comfortable, do it. So that's that. Okay. So I think this question I did not really talk much about it during my explanation, but the point I'm just going to make here is that we don't need to read the question. The point I'm just going to make here is that people on maybe hospice care or palliative care, you might not really need to what's it called, to be treating diabetes in them. You don't need to treat, even if you want to give them anti-diabetic medication. Sorry, you might not need to treat hypertension, because hypertension is like you are trying to be prolonging life and all those things. You don't need to place them on antihypertensive. You can place them on anti-diabetic medication. The reason is that people on this palliative or this hospice care that are diabetic, they could have DKA. And we remember that one of the cardinal signs and symptoms of DKA is what? The cosmo breathing. You could be having some form of breathlessness. So you don't want that one to happen, because it's going to worsen their quality of life. It's going to bring them down totally. They are going to be suffering, so you don't want that to happen. So you usually place them on long-acting insulin, like insulin glargine. So they place them on long-acting insulin. The reason is that if you see short-acting insulin here, you don't pick it. Because if you are giving somebody short-acting insulin, you have to be checking the blood sugar level from now and then, be picking them, be doing blood tests. It's stressful. Somebody on palliative care choking every time now and then. So just give them long-acting that you know that, okay, you are sure that there's going to be sustained level in the blood for a long time. I don't need to be worried about the blood level, the blood glucose, level. So it is acceptable for you to place somebody on palliative care, place them on what's it called? Long-acting insulin, but you don't place them on antihypertensives. You don't place them on antihypertensives. You don't. So that's why the best answer here would be discontinue ramipril. So that's just for our information. Let's just have that information with us. Okay. So let us move on to communication. Communication. So, of course, when we are interviewing our patient, we need to make sure that the patient are very comfortable, and there are some certain rules that we need to follow. And this is what is being listed here. We need to set the stage. You need to introduce yourself to the patient. Hello, I'm Dr. Babawale. I'm going to be your doctor for today. How would you like me to address you? That's the thing. Don't assume that the patient is a man like we do in our country. No, it doesn't work there in the US. Somebody can be a man and the person is not saying that he or she is a man. You know. So how would you like me to address you? She, he, him, her, all those kind of things. So the person is now going to tell you, address me as Mr. This or Mrs. This. Then you now, say what you are going to be doing. So I'm going to be the physician that's going to be attending to you today. I can see you have somebody with you. Do you want the person to stay with us in this meeting, or you like the person to excuse us? Setting the stage. That is it. Because some of them, they can come with their caregiver. So very, very important stuff. Then the next thing is to setting um, the agenda of the interview. So you are going to tell the person, I think I have a note there. So just to guide us, you are going to tell the person what you are going to be doing and how you are going to go about it and the time it's going to take you to run through the process. So before we begin, you can say something like, before we begin, I would like to know what concerns you have today. Could you share me the main issues you would like to discuss? We have about 20 minutes. So I want to make sure we cover your most pressing concerns first. Agenda of the interview. 20 minutes, and I want to make sure that we cover your most pressing concerns first. After you have set the stage, then the next thing is to, is the non-focused expression or reflection. So that's when you're not going to be starting with open-ended questions. So can you just, tell me what brought you to this facility today, and the person will now start talking. Now, when the person is talking, you have to observe the facial expression, the body language of the patient, and you have to show engagement. You have to show engagement. And how do we show engagement? You nod when the patient is yeah, okay, and you maintain high contact. You are looking at, not that the patient will be talking and will be okay. It's just sad that we can't see me right now, but we can picture what I'm doing. Somebody is talking and you are now using the opportunity to be looking for paper. Okay, I'm with you. That kind of thing is wrong. So you have to show that you are actually engaged with that conversation. You are showing engagement. Can you tell me about what has been going on with you lately? Make it open so that the patient can go to town and be talking. And from there, you will not interrupt. Don't interrupt. Let the patient talk. Let the patient talk. So then the focused expression of validation, um, it's just getting the patient talking. And if the patient now talks to you, maybe the patient says, I'm feeling worried. Then you now use the nurse technique. You see, this nurse technique is very, very good to show empathy. Very important. The nurse technique. So the N for naming, the U for understanding, the R for respecting, the S for supporting, and the E for exploring. So let us take them one by one. So the patient comes to us now. Doctor, I'm feeling so down. I'm feeling so worried, blah, blah, blah. Okay, so using naming technique, the nurse technique, where the N is standing for the naming. So I think I have some clue here. So the naming, you have to name what the person is going through. So I can see, you are worried. Oh, so that you have named that emotion. It sounds like you are feeling worried. You have named it. Then the next one is now, understanding their perspective. So they tell you that, they are feeling worried because, all their children are abroad. They are the only one at home, just down, blah, blah. So you understand their perspective. That you say something like that makes sense given what you are going through. I can see why it's challenging for you. So you can understand from their perspective the reason why they are worried. So somebody comes to us now, the person was like, Doctor, no, Dr. Festus, I'm so worried by my step one. It seems that I cannot pass this thing. I open first aid, this stuff is just too hard. So you try to name, I can see that you are overwhelmed. That's naming the emotion. Understand their perspective. Yes, given the fact that you have left medical school 20 years ago, all these interleukin 12, all these things, yes, definitely, it's going to be hard to remember. It's going to be challenging. You are understanding their perspective. The R is going to be respect their experience. It's not as if you start whining them, but just you encourage in a way. I can see you are actually handling, despite the fact that this thing is challenging, you are still making effort to come to the hospital. You are still making effort to reach out to Dr. Festus. You respect their experience and try to encourage them. You have been handling this very well. Then the S is now going to be support. Don't worry, we are going to work on this together. Support them. We are going to see through this together. I'm always here. If you have any challenge, reach out to me. If you have any difficulty, reach out to me. We are going to work together. Then the E is now the explore. So can you tell me about anything else that worries you? Or can you tell me about, anything else that you find difficult? Just try to explore whatever feeling they might be having that they are not telling you. That is your nurse technique to show empathy. Don't forget, very, very important. They can give you a clinical scenario and they make a statement, they quote a statement that the doctor have made, and they ask you, what component of this disease is this doctor eliciting? Is it naming? Is it understanding? Is it respecting? Is it supporting? It is now left for you to now be able to recognize what that doctor is doing. Please don't forget what we have talked about. Very, very important. Then you also try to recapitulate. Yeah, so you have told me about issues that have been bothering you so far. I understand that it's because your children are not with you. Am I right? Recapitulating. Am I right? Did I get that right? Is there anything I'm missing? You know, recapitulating like that. Then facilitation. Of course, during the course of the discussion, you always encourage the patient to be free. You can tell me, you can tell me anything. Please feel free to tell me anything that's bothering you. You're facilitating. And of course, make the questions open-ended. Don't say, uh, uh, um, you ask a question and you're saying, Abi, yes or no. That is not an open-ended question. You throw it out. Can you tell me more? Talk to me about this. All those kind of things. And don't forget the emotional seeking skills, looking into their eyes, showing engagement, repeating what they have said to show that you actually understand them. And of course, showing empathy through the nurse technique. Very important. Let me see if we have any question here. We do not. I'm so sorry about that. Okay. So, what about the effort to establish rapport? Everything just works together. To establish rapport, you use the peer model to establish rapport. It's very straightforward. The P for the partnership, the E for empathy, A for apology, R for respect, L for legitimization and support. Yes. So partnership, you're always making statements that don't worry, we work together. Once you are seeing the question that they are making statement that working together is there, just go and pick partnership. Partnership, very important. So working with the patient to identify primary problems and preferred solutions. Don't worry, you may have some difficult times ahead. We'll work together to provide you the best possible care consistent with your goals, your values, and your beliefs. Don't forget, everything with respect to patient care in the USMLE is patient-centered. Don't forget that. It must be individualized. So for this patient A, we are going to tailor the treatment to the patient's goals, the values, and their belief. Because culture can alter their belief. They might have some different belief, cultural belief. So you have to make sure that you are open, you are culturally sensitive, and you can deliver a patient-centered, care. Then empathy. We have talked about the nursing technique. Always show empathy. You can see you appear sad. What have they done? He has named it. You appear sad. He has named. I understand. It's showing understanding that the news of your illness may have upset you. Very simple. Empathy. Then apology. Probably you came late. Apologize. I'm sorry, I came late. I am so sorry about that. I apologize. I would still like to understand your concerns so that I would like to help you. Never pick an option that is doing explanation. Never pick an option that will do explanation. So sorry, there was a traffic there. It's not as if I'm a late doctor. I'm not a late doctor. I'm very punctual. You are explaining. You don't explain. Apologize, get right to the matter at hand, and move on from there. Don't try to justify your lateness. That's going to be wrong. Respect. We have talked about respect, something that looks like you are whining or you are not whining. Encourage the patient. Despite the fact that you are going through this tough time, you are still, trying to stop taking alcohol. You are still trying to go to rehabilitation. You are still, encourage them, so that they can navigate through that situation. I know you are giving your best every time. You are respecting them. Legitimization is very similar to understanding. But in legitimization, what you are doing is that you are telling them that what they are feeling is normal. So, you are validating the patient's emotions and letting them know that the way they were feeling, is actually normal. Because some people start overthinking that, why am I feeling this way now? You try to tell them, yes, somebody that their child is abroad, they will feel depressed. It is normal. It is human. You are legitimized, doing legitimate. You are making sure that you are validating their emotions. So that is legitimization. So, trying to reassure them that what they are feeling is normal. Then, of course, supporting, reassure them, tell them you're always going to be there for them. You guide them through the entire process till they are okay. So let me see what I have here. Okay, let's look at these few questions. So please, am I too fast? Hope you understand what we have been discussing, or am I fast? Okay.
So far, so good.
Okay, that's fine.
Thank you.
So this is a 56-year-old man with a history of type 2 DM, hypertension, hyperlipidemia, who presents for a routine follow-up. His recent calculated hemoglobin is 9.2%, despite taking metformin and following dietary changes. The patient appears frustrated and says, I have been trying to eat butter and walk alone, but nothing seems to work. I don't see the point of all this medication if my sugar is still high. Which of the following response best demonstrates partnership in communication? A. It seems that you are struggling to follow the treatment plan. Maybe we need to revisit your efforts. B. Managing diabetes can be tough, but let's go over what's working and what's not. We can adjust your plan together to make it more manageable. Diabetes is a progressive disease, and if your sugar remains high, we have to add insulin. D. You need to make more significant changes if you want to see results. Which one demonstrates partnership? Anybody?
B,
B.
B for boy.
B, exactly. B for boy.
B.
So yes. So let's go over what let's work together. Once you are seeing that, let's always have a very high, like, look out for all those kind of things, like working together with the patient. It's always going to be correct. They like all those kind of things. Let us go over what is working or not. Then we can adjust your plan to make. Trust me, if we go to UWorld, those things that we are going to see in UWorld, that's not what they are going to test in that exam. I can assure you. It is much more simpler than all those things they are putting in UWorld. That they are just, if you go and stumble on all these things in UWorld, ideally, somebody might just be banging everything. Yeah. But it's not truly a reflection of what you are going to see. It's just simple stuff that they are going to be testing. They are not complex at all. I can assure you. So, a 28-year-old medical student presents with severe test anxiety before an upcoming board exam. She says, I don't know why I get so anxious before exams. Maybe because I'm just weak. She reports difficulty sleeping and she has frequent panic attacks before exam. Which response is going to be most appropriate? So this is a student that is having test anxiety because she's having an exam, and she said, I don't know why I get anxious before exam. Maybe I'm just weak. She reports difficulty sleeping and has frequent panic attack before exam. So which response is the most appropriate? A lot of students feel this way. You just need to push through it. Feeling anxious before exam is completely understandable, and many students experience it. Let's talk about ways to help. Anxiety is common, but you need to learn to control it better. so that they can even put it in the exam so that you don't fail your exam. They'll put some level of urgency in it. You should try meditation or exercise to calm down. What do we think is the best thing here?
B for
B.
B. So what do we think that person is doing?
legitimization.
Legitimization. Legitimization is completely understandable, and many students experience this. Let us talk about ways to help. That is legitimization. It is as simple as that. So once you hear pairs, don't allow people to bobo. Do you know the pairs model? You are going for exam, you don't know pairs. This is just what they are saying. Nothing hard about it. Establish rapport with the pairs. Challenging conversations. So this is just like breaking bad news. I'm sure that most of us were already familiar with this one. We use a spikes model to break bad news. Spikes model. So S for the setting, the P for the perception, the I for invitation, the K for knowledge, the E for emotion, and S for strategy. So the S for setting, so you want to look at it. That's the first thing you are going to be looking at in the question. Is there anything that talks about setting? Have they addressed the setting? That's the first thing you are looking out for. We are not going to be jumping to invitation or knowledge. Setting first. Is this environment private enough? Would you like this person to excuse us before we deliver the bad news? We are not going to say that before we deliver the bad news. Just say that before I tell you about the result of your test. Coming to ethics, some people will even tell you that they don't want to know the result of your test. They will tell you that. The best next step in that situation will be, I'm just saying it now in case I forget to mention it there, is that you can ask for, surrogate decision maker. Do you have anyone else that I can tell? That's going to be your answer. Go next best step. Because you must tell somebody. You must tell somebody. So, although there's something called therapeutic privilege that we are going to talk about too shortly, I'm just going to be dropping all those things now so that by the time we get there properly, we are already used to it. So, because there are some certain news that, although it's normal that you must disclose any bad news you must tell them. But sometimes, if the relative give you an hint that, that stuff might cause grave harm, or something to the patient, and the patient might commit suicide or kill himself, you might work with the principle of therapeutic privilege and you withhold that information. But ideally, patient autonomy, they have the right, to know their medical information. So look at the setting. Is it private enough? Do you have the right people that they want to be in that room? Are they there? Yes. Before you now start talking. Then the next thing is perception for the spikes. P for perception. Perception. You want to know the perception. Why do you even think we are doing biopsy in the first instance? Why do you think we are doing your blood check? Or what do you know about your condition? Asking about the perception of the patient before you deliver the news. Then the I is for invitation. So not all the patients want detailed medical information. They don't want you to be telling them a lot of stuff. They can tell you just make it succinct, make it brief. So we tell you, please go to town. Let me know. I want to know everything about what is happening to me. And of course, you have to avoid medical jargon. That's not the time we now be saying, it is due to some anastomosis between the internal jugular artery and the blah 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 artery. No, you are going to break it down. Make it concise and easy to explain. Invitation. Sorry. Yeah. So invitation, right? So just asking about the amount of information that you want the patient to know. If you want it brief or they want it, well detailed. Then in knowledge, you now start telling them small by, small pieces, making it, don't use medical jargon, just explain it, and of course you have to assess their understanding do you understand what I mean by that? So this is what I'm sorry, but I'm afraid, you might have, cancer, I wish I had better. So you have to be careful to be using the word I'm sorry. you can see that means you are already making a mistake because you are used to it. So don't say I'm sorry. So I'm afraid that you might have a diagnosis of cancer. I wish, we had some better news. Those are the certain words you want to be using. Don't say I'm sorry, you have this. No. So emotions. So if the patient is crying, so you have to validate their feeling. I know this is hard to take in at this time. If you have handkerchief, you can offer them to wipe their tears and all. Just be empathetic. Don't be mean and be talking to patient and you are thumping some doctor, I go see you, I go see you. You don't do all this kind of thing. You have to be empathetic. You show remorse with them, and you try to offer them some form of comfort, at the same time. The strategy, how you want to move on from there. So, given what have happened, we can still proceed by doing this. We can work together on a plan, that focus on your comfort and quality of life. I would like to connect you with a specialist who would guide you through the next step. That's that strategy. So you want to summarize all the discussion we have had in a very simple term, then you start discussing the next steps. Offer hope, even if the situation is difficult. We would like to work together on the plan that focus on your comfort and your quality of life. So that kind of statement now, you are not saying that the person will get well. So you are being careful. You said comfort and quality of life. Looking at something that looks like palliative. You just say, don't worry. We'll see to it that you are going to get better. Don't make false promises. Very, very important. So that is a spike, setting, perception, invitation, knowledge, telling the patient, being there emotionally, and the strategy. So let us see. I think I have, some questions here. Let me see what I have here. Okay. I think I have one or two here. Yeah. I'm so sorry about this. Okay. So, a 68-year-old man with a history of chronic smoking and weight loss undergoes a lung biopsy, which confirms small cell lung cancer with MET. The patient's son privately requests that you should not tell his father about the diagnosis, fearing it will kill him emotionally. When you meet the patient, he asks, so is it cancer? What's your most appropriate response? This is funny. Sorry about that. What's your most appropriate response? A, your son prefers that I do not disclose the diagnosis to you at this time. B, I will respect your family wishes, so let's focus on your treatment. C, before I answer, what do you understand by your condition? D, you do have cancer, but let's discuss our treatment option together. E, I can only share information with your family for now. Anybody?
See, before
See,
answer, what
Yes,
do you understand about it?
exactly. So that means that they have jumped in this situation now. They have jumped to perception. So, but if there was a answer that talks about setting, we'll have picked setting first. Are you comfortable, getting that answer in this environment? That's setting. That would be picked ahead of before I answer. What do you understand about your condition? So that's very good. A 67-year-old woman comes to the physician to discuss the result of a colonoscopy performed 1 week ago. The patient immigrated to the USA from Indonesia 4 years ago. She is accompanied by her daughter and a friend. The woman and her daughter have both been patients at the physician's practice, but the physician does not know the patient's friend. The office is relatively small, and everything that is said can be heard by everyone present in the room. After a self-introduction and greeting everyone in the room, which of the following is the most appropriate initial action by the physician? Politely ask the bystander to leave the room. Begin the consultation with the bystanders in the room. Ask the patient whether she would like the bystanders to be present. Politely ask the patient friend to leave the room. Which one is the best?
see,
C.
Yeah.
C.
The patient.
Yes. So politely ask the patient whether she would like to, you have to always ask them. Don't make decision for them. Ask them. Yeah. Okay. So so once it's 3 o'clock, we just
I,
take a break. Yes, doctor, I'm with you.
yes, sir. Yeah, in situations where you have the bystanders there, the person wouldn't want them to really witness the information delivery, but but the person finds it difficult to let the doctor know that I don't want them to be there because it a kind of situation where they are there and then they might think that you are comfortable with them hearing the information, but you actually, as a patient, you are not comfortable with that. But you are trying to say it to the doctor directly in their presence that you are not comfortable with them hearing the
Okay.
information delivery. That kind of a situation.
Ah, I get, but that's a very hard one. Like, so what you're trying to say is that the patient doesn't want them to be there, but
Mhm.
the person is just maybe not too comfortable because he doesn't want the person to feel bad, the relative to feel bad that
Y-
he or she is
Yes,
excusing them.
exactly.
That's a very tricky one. But I
And
don't think.
the doctor asks him
Mhm,
in their presence, "Do you want them to be here while the information is being delivered?"
mhm.
Yeah,
I
so I'm
think
not sure if the doctor can take a discretion of like,
of reading that
tell it-
emotional.
yeah, yes,
Ah,
in the patient and just tell them to excuse the patient because they are about to discuss something.
the thing is, I've never come across
Come
that kind
across
of
something like that.
scenario before.
Scenario.
But I think well, ah, because we are not getting it from the patient. So working with emotional cues on the patient might be a little bit tricky because it might be a case, and they'll be asking you, you know, why did you act like that? Why did you allow the relative to stay or something? The patient might sue. There are some people that can do that. They can sue, and the doctor will not be able to defend him or herself. Just looking at but ah, but you were looking as if you wanted those guys to leave now. The person will just be like, "Who said? Did I verbalize it? Did I tell you?" No, there's no witness. So but I don't think it can get to that level. I don't think
Yeah.
so. So they
So
will
you
just
just have to always ask the person.
yeah. So it is
Yeah.
that asking
Thank
that they
you.
will test in the exam. The
Mm.
only condition I know that they can ask that you might find yourself in that kind of difficult situation would be in the situation of abuse. So they can ask you in that kind of so they will be like so they can just give you a scenario in which somebody's abused. So that is why we as doctors we have to be able to identify the cardinal signs of abuse. We cannot go for our exam and we don't know abuse. It is impossible. It is very, very impossible and dangerous. So you have to know. So once you see this sign, you are seeing all this metaphyseal fracture, subarachnoid hemorrhage, or you are seeing fracture of the tibia, the long bones in a child that cannot even walk, all those kind of things. Or maybe they are raping somebody, and you are seeing bruising in the private areas, all those things, and you are suspecting abuse. So if you ask that kind of person, maybe the parents are the one abusing, right? And if you are, would you want to interview that person alone? Because that's the best next step. Interview alone. So if you want to interview that kind of person alone and the relative don't want to go, or the patient is reluctant to tell you that the father or mother should go, you know, you might actually act based on your physical findings because you have something to actually document that I did my examination and I noticed that um what's it called the child is having some certain features that look like he or she is being abused because I can see the bruising, I can see the metaphyseal fracture, I can see the what's it called the rib fracture, that looks like some form of abuse. So you can act based on that. Sometimes they might say that okay, if they are not living true, you can maybe you want to examine, you can ask for chaperone to be there and all those things. So, but don't worry, I don't think you can get to that level. They are not that wicked to put us in a very difficult situation like that. So, but that's very good stuff to think about. Yes. So, um, gender and sexuality inclusive history taking. So you want to interview a patient, there's nothing
Sorry,
more
Doctor.
to. Yes.
Sorry, Doctor. Please, I want to ask if that last question was a case of assault, does it mean our answer would change?
Let me see the answer we have there. Let me see. No. It will not still
That
change. It will still ask the patient.
politely ask.
No.
Okay.
We'll still ask the patient first. We'll still ask the patient first. That's always it, because autonomy, don't forget. Autonomy, patient autonomy. So ask the patient whether she would like the bystander to be. That will still be the answer. If but they will not really put it. I don't think that they can put this kind of option there if it's going to be like assault. If it's assault, it's likely that they will just tell you politely ask the bystander to leave. That's what it's going to be. Politely ask the bystander to leave the room because you need to talk to the person alone. Because that one is much more urgent. Do you get? But if you have this kind of option being there, the best thing is to actually ask the patient first. You don't understand, doctor, what I'm trying to say. I don't
Yeah,
want to
I do.
confuse you.
I, I
If
get.
the list is like this, C is the
Okay.
best. C is the best. But you can have a situation like in assault that C will not be there. But you can find something like A there. You can see A there, you can see A there. So just tell them to um excuse you to interview that child alone. Very important. Interview the child alone. Then after that, you can now report to CPS, Child Protective Service. Don't worry, we'll get there. We'll get there. So we'll talk more about it. Okay. So so gender and sexuality inclusive history taking. So when interviewing the patient, you always want to take into consideration the following points. So you don't make assumption. Don't forget, we have already said it. After you introduce yourself, you want to ask, how may I address you? So they'll not tell you, call me Mr. This. You don't assume that they are guys or they are males or they are females. You don't assume their sexual orientation too. So you want to say that I can see that your partner or your spouse is here. Don't say that I can see that your fiancé or your fiance, because you're already assuming that they are man or they are woman. So use something that is neutral. In terms of sexual orientation, gender identity, gender expression, or sexual behavior, you have to ask them first. Don't assume anything. And if what you are seeing them for does not require you to be asking about their sexuality or their gender, don't ask it. Don't ask it. For example, how long have you been smoking? The person is coming to you because of case of smoking issue. You don't need to be asking that, are you a male or what's your sexuality? Are you gay or you are lesbian? You don't need that. It is not relevant. You know. So note that the patient can identify different gender than the sex that was assigned to them. I think I have some notes here about that. Yeah, I have something here. For example, um some medical condition or treatment may have gender-specific considerations, but always approach this discussion with sensitivity without making assumptions. So, example, a breast cancer in a transgender man. So, transgender man means that is what the man changed to. So, transgender man is going to be a woman that is appearing like a man. So, you don't say that you are a woman, you need to consider breast cancer screening. No. So, you can say something like, based on your medical history, it is important that we discuss breast cancer screening options that are relevant to you. Because somebody that is a transgender man is a woman that is changing to a man, that is saying that he or she is a man. So that's the best way. You are a woman, that is true direct. You don't say that. So always try to use gender neutral terms, partner or spouse. Don't say fiancé or fiance. And always reassure the patient that whatever information that they share with you is confidential, and you are not going to diverge it to other people. You're not going to let them. You don't talk about their sexual orientation or gender identity to other people without their permission or request. So you can disclose it with their permission or request. So let us see. Okay. So this is a 25-year-old transgender woman assigned male at birth who present for a routine physical exam. She has been on hormone therapy, estrogen and spironolactone for 3 years. Why taking the... Anybody knows the reason? I'm digressing a little bit. Anybody knows the reason why this person can be on spironolactone? Anybody knows?
Because of a citizen.
Aldosterone antagonist.
It is what?
Aldosterone antagonist.
Exactly. No. Yes, it is an
Because of a
aldosterone.
citizen.
But why do you think they can place somebody? Dr. Babandi will have thought of
For
this.
breast growth.
Because of air.
What other effect does spironolactone have?
It's a side effect of gynecomastia it produces.
Breast.
It
Why?
reduces the
Why? We need to know why. Why is
it
it?
reduces air production.
No.
Androgen receptor
Androgen receptor
antagonist.
antagonist. That is it. You have to know why. When you know why, you can never forget. When you know why, you can never forget why they are causing gynecomastia. But if you are working with they cause gynecomastia, you can forget. But once you know that it is an androgen receptor antagonist, you know that androgen have no role again. Estrogen becomes the major hormone. And estrogen will go and stimulating the breast. Gynecomastia. Very simple. Androgen receptor antagonist. And it's very good for this guy because this guy wants to change to a woman. So give spironolactone and let the breast be coming out. That is it. So while taking the history, the physician refers to her as E and ask, when do you decide to become a woman? The patient appears uncomfortable. The doctor has messed up already. So which of the following is the most appropriate response to improve communication? So let's take them one by one. I apologize for using the wrong pronoun. How would you like me to address you? You were born male, so I would refer to you as a male for medical accuracy. I don't mean to offend you, but we need to focus on your health. I would use E because I need to document your biological sex in the medical record. Why don't you tell me about your gender transition process before we continue? Anybody knows the best?
I'll
A.
go with
I
A.
think
Yeah.
A makes sense.
A.
Exactly. A is the best. E is very funny. Why don't you tell me about your gender? You are even assuming that the person has changed,
E.
So A is the best. I apologize for using the wrong pronoun. How would you like me to address? Very important. Don't worry. When you get to the exam, you are going to be seeing some funny questions. So be prepared. US at MBME, they are, I don't know what to say about them, but always be prepared because once you work with understanding, you are going to be very all right. I can assure you. So this is 3:05. Let's just go on like 20 minutes break and we come back by 3:25. Is that okay?
Yes, sir. Yes, sir.
All right. Thank you. Hello everyone. Are we back to the... Can we hear me? Okay. Yes. So moving on to the culturally inclusive history taking. So just like we have said, we have different patients that have their own cultures. They have specific goals, values, and beliefs that they are working with. So sometimes we might propose some treatment to them and they don't accept it because of their own culture. So we have to understand whatever they are going through from their own experience, from their own perspective. So I have some notes here. For example, some patients might believe that some illness that is happening to them are caused by spiritual factors or karma or chi or energy imbalance rather than infection or organ dysfunction. So what you want to do, most of the situation that the USMLA will put us in is ability to test, like to inquire about their own understanding. So they are not really going to put us in what are we going to do if somebody says it's karma, like how are we going to treat them? No. So the initial thing is what they are going to ask. Don't forget, the USMLE is an exam for the American graduates, like for the people finishing school. So not really for board exams like people doing residency. So it's the basic things that they are going to be testing. So the first thing you want to do is just to try to understand, why they are having that kind of perception. Like, what is their belief? So how do you understand what is happening with your health? You know, then um so try to understand, so the first one is to try to think about the illness from patient perspective, by asking questions such as what do you how do you understand what is happening with your health, so that you can get to know what the patient is feeling. Then also try to understand what factors in patient cultures or background, like all this Jehovah Witness, that's a form of culture in a way too, you know, um, because certain religious beliefs, like people from the Jehovah, Witness group, they might decline blood transfusion, vaccination, and even life-sustaining treatment. Or some people might have experienced some previous medical trauma. Maybe a patient saw a family member that had a very bad surgical outcome, or maybe died during surgery, and since then they have made up in their mind that they will never, go for surgery. So try to make inquiries about why they are, sticking to a particular plan, or why they are refusing a particular plan. That's going to be the correct answer in most of the situation. And about this Jehovah Witness, don't forget, patient autonomy, yes, more than 18 adults. At that point, they can make medical decisions. In as much as they are competent, so they can make their own medical decision and refuse blood transfusion, right? If it's an adult and they are competent. But they cannot refuse treatment for a child. So these are another place that they can wait for us. So they will say that the person is a child of a man who is a Jehovah Witness. And they said that the child just had a heart and needs blood. You are not going to listen to the parents. You are going to go ahead to transfuse them. You must go ahead to transfuse them. What they can refuse for a child, USMLE, is vaccine. If they say that they don't want vaccine for their child, don't give vaccine. You can just encourage them. Maybe that's what you are going to see in the question or the option. Like maybe give pamphlets, recommend materials that can further enlighten them about the benefit of vaccination. But you must never force it out. You say, no, vaccination will prevent measles. Oh yeah, come and take vaccine. That's going to be wrong. We are going to talk about some of those scenarios a lot. Like we'll mention a lot of them because different principle works different things. If it is an emergency, baby is bleeding, needs blood, go and transfuse blood. If it is not a case of emergency, probably the person has cancer and, maybe the person is having anemia. The anemia of cancer, that's an anemia of chronic disease. It's not life-threatening at that point. So you don't need to go ahead with transfusion, even if the parents are refusing. In that kind of situation, you can go, probably get a court order or something, to overrule the decision of the parent. So you need to understand the urgency, or the emergency with respect to the situation before you know the best next step. Very, very important. So, motivational interviewing. Okay, so most of the time they use motivational interviewing for people that are undergoing maybe some form of drug issue, substance abuse, or there's a particular behavior that they are doing that is actually bad for their health. So you are trying to encourage them to stop it. For example, someone that is an alcoholic or a smoker, you might I think I have a question here. We'll come back to it. You might want to always encourage them to stop smoking. Don't forget, smoking is is the most important risk factor for cardiovascular. Is a problem with respect to the USMLE. Smoking is a problem. You don't joke with smoking. If you see something that talks about, look at it clearly, before you do anything, because smoking is a problem, even far more serious than hypertension. So I don't know, maybe because all these white people take a lot of cigarettes, so they develop a lot of problems. So always look at smoking seriously. So let us just solve this question and move on from here. So this is a 43-year-old Jehovah Witness man who is admitted for severe gastrointestinal bleeding due to peptic ulcer. His hemoglobin is 6.5 and is hemodynamically unstable. The medical team recommends an urgent blood transfusion, but the patient refuses, citing religious beliefs. What's the most appropriate next step? Proceed with the transfusion under emergency medical necessity, respect the patient refusal and explore alternative treatment, obtain a court order to allow the transfusion, consult the patient family to override the decision, transfer the patient to another hospital where blood refusal is not a policy issue. Anybody?
B for boy.
Yes. B for boy. Respect the patient refusal and explore alternative. Maybe you want to give plasma or something. That is it. So that is B, because this is an adult. It's competent, and the person is an adult, so you have to respect the patient refusal. So this is like overlap between ethics and all this cultural stuff, because this is working with autonomy principle. Respect patient decision. Okay. But don't forget, if it's actually the child of this kind of person that is less than 18, you must, go ahead with the transfusion. But if it's not an emergency, you can obtain a court order. So a 54-year-old Chinese woman presents with chronic back pain. She says she has been using cupping therapy and acupuncture, but wants to discuss additional treatment options. She expressed concern about using medication because she believes her pain is due to imbalance of energy. What is the best next response? A. Acupuncture has no scientific evidence, so I would not recommend it. B. We should focus on proven medical treatment and avoid alternative therapies. C. Tell me more about your experience with acupuncture and we can explore treatment options together. D. You need imaging studies first before we discuss any treatment. E. If acupuncture has not cured you, you should stop using it.
See.
Hello? What do we think here? Huh?
C. Tell me more.
C. Tell me more. Tell me more. So you have to look at it from the patient's perspective. Don't say that we should focus on proven medical treatment and avoid. So you are not doing patient-centered care. You need to, hear what the patient is doing. All right. So talk about the motivational interviewing. You are trying to interview, encourage them, to stop that particular behavior and set some goals for them to work with. And what are the criteria that must be met for a particular goal that you must be choosing for them? SMART. S for specific, M for measurable, A for achievable, R for relevant, and then T for time bound. So a very good example is going to be somebody that is obese, right? And the person comes to you and tells you, doctor, see my weight, I am weighing like my BMI is like 60, morbidly obese. And I want to quit. I actually want to stop eating junks. I want to lose weight, but it's just that I love chips. I love chicken and chips a lot. I love eating meat pie. It's difficult. So we are going to get to some stages of all this motivational stuff, this behavioral changes stuff. We are going to get to these stages. We are going to understand what each stage involves and how to take care of it. We are going to get there. So here, just like we have said, the SMART approach. Your goal must be specific, measurable, achievable, relevant, time bound. So obesity, the goal is lose weight, but you have to make it specific. So we want you to lose 5 kg. We want you to lose 5 kg within 3 months. That is specific. That is relevant. Because if the patient loses the 5 kg or the 10 kg, it is going to help the lifetime of the person. The person is going to be healthy. Notice for hypertension, DM, and the likes. Relevant. Time bound. 3 months. Right? Is it measurable? Yes. As the person is, each month you can measure the weight. Okay, how many pounds have you lost now? You can measure it. Is it achievable? Yes. If the person is consistent with the diet, the exercise, the brisk walking, everything, the person can achieve it. So any goal you are going to be setting for your patient must be realistic. It must be measurable, must be specific, time bound, and just meet the SMART criteria. That is all they are talking about here. There's no need to waste time. So, communication with patients with disability. So the first thing is that you want to ask them, when you're talking to a patient that has disability, you want to ask them, how do I address you? Person with a disabled or disabled person? Depends on the preference of the person. And you must allow them to do what they can do by themselves. Promote independence. Don't say, let me help you carry this, because you are feeling that the person cannot walk well. You can ask, do you need assistance? Don't go ahead and do it before you ask. Do you require assistance before you? Don't assume that they cannot do something. You just take brush. You are combing the hair. You have not even asked the person. Can you use the brush? So people that are having speech difficulty, give them extra time for an interview. That's not the time to be rushing them. Let them talk. You already know that they have Parkinson. They're having micromania. The speech is not really gallant. Give them time to talk. Some form of Alzheimer's is there, cognitive impairment. That's not the time to be using, broad diagnosis and be confusing them and be telling prosopagnosia. You're having prosopagnosia. What does that mean? So you break it down, use very simple words, and direct questions too, so that they will be able to answer you very easily, and also for the people that have difficulty hearing. So you want to ask them about their preferred mode of communication, ask them about the preferred mode of communication, and you might need to use an interpreter. Interpreter is a big deal in the USMLE. You can come across this in your exam, even in the questions that we solve, they are there. So we are going to talk about it shortly, just next after this. So, ask them about the most preferred mode of communication. If they require an interpreter, provide an interpreter. So also, if somebody is disabled, don't bring up the disability when it's not relevant to the presentation. And also do not skip portions of the physical examination, even if the disability makes the exam challenging. Find a way around it. If you want to examine them, you can still examine them on the chair. Just don't say that, sir, because the patient cannot stand up, I did not do musculoskeletal examination. Nobody wants to hear that from you. Don't skip any part of the examination because you think that they're having some disability that can impair them. So for the interpreters, very important. So when patients do not speak English or they have difficulty, they can speak little English. Always the best next step is to get a professionally trained medical interpreter. Look at the word, professionally trained medical interpreter. Unless you are the doctor, you can speak Nepalese, or you can speak Portuguese, or you can speak Igbo. If you cannot speak the language of the patient, the next thing is to get a professionally trained medical interpreter. That is what you have to do. So sometimes they might tell you that this is an emergency and you cannot speak the patient language, right? So what are you going to do? So if it's an emergency, you can work with what you have. If the patient relative can speak some little English, they can help you translate quickly, or if you have someone around that can, speak language that is commonly understood between the physician and the client and the patient, use the person to do the transcription for you. But if it's not an emergency, and a professionally trained medical interpreter is not available in person, the next best step is to use a phone call. You can do a telephone or a video call to deliver the same service. Very important. Very, very important. If it is not a situation of an emergency. But if there is an emergency there, you can use, friends, family, interpreter apps, just to save that life. Very important. Very, very important. I think there's something I'm missing here. I don't know. Um, yeah. So just make sure that you are looking at it when you are doing the interpretation stuff. You are talking to the patient. You are not talking to the interpreter. You are talking to the patient because it shows that you respect the patient. You are looking at the patient and you are not using third word. You are not saying she, referring to the patient as she or he, third person. No. So even though you are looking at the patient, you are still saying that. So I want you to know. So the interpreter will now be transcribing it like that. That the doctor wants you to know. You're not going to say tell him that or tell her that. No, you. So you are having this, all those kind of things. You look at the person. You use all those kind of direct words. Very, very important. Very, very important. So moving on to, I think we have like a question here. Let me see. Okay, so just brief, introduce a interpreter to the patient. So stand. Um, so the position of the interpreter should be behind or next to the patient, but that you are the doctor, you should be in front of the patient. So address the patient, maintain eye contact with the patient. Avoid third person statements, just like we have said. Use teach back method. You cannot go for your exam and you don't know what is teach back. It is dangerous. Very simple. It's as simple as you tell the patient something. Later, when the patient is going, you ask again. So, how did I say you are going to use this? Patient tells you. Teach back, very effective. You don't assume. Teach back is very, very effective. It's very similar to closed loop communication between physicians or between healthcare workers. You tell matron Lagbaja, I have given that patient 20 milligram midazolam. So matron Lagbaja has to use closed loop communication to be safe. Patient safety, to be safe. So matron Lagbaja will now tell you again, okay, doctor, thank you, sir. But you said 20 milligram midazolam, right? Yes. You will now answer, yes. That is closed loop communication. Very, very important. It's very similar to teach back method here. You tell the patient, this is how you use the drug. You take this one in the morning, this one in the night, 20 milligram in the morning, 20 milligram in the night. Oh yeah, tell me how we are going to use it. Thank you, doctor. I take 10 milligram in the morning, I take 10 milligram in the night. That is it. Teach back method. It is as simple as that. So, moving on to the behavioral counseling. So, when we are offering counsel as a clinician, you should tailor the education and suggestion to the individual patient, and also depending on the stage of the change. So this is not like stage of change. Somebody is having problem with drug use. So there's different stage of change. We have the pre-contemplation change stage, the contemplation, the preparation, action, and maintenance. It's very simple. Don't worry about it. I don't know if I have another example here. Yes, I have. Now, so the pre-contemplation is the first. In the pre-contemplation phase, just like we have here, they are in denial. They don't even know that. They don't even see that the problem. That's the thing. So they can be like, you can tell them like, okay, just come to you and you are just telling them about, you just notice that the weight is too like high, like 40 for your BMI is 40, 50. And they tell you that the grandpa, I'm sorry, doctor, but my grandpa weighed over 100 kilograms and is still living up to 90. I don't see any problem with my weight. That is denial. Ignorance of the problem. The stage of change at that point is what? Pre-contemplation stage. Pre-contemplation stage. They are still in denial. So that kind of person, what you want to do next is like you want to try to facilitate introspection. You want to ask them, like, why? Probably if they are the type that like they like smoking. So like, what do you enjoy about smoking? Like, what makes you want to smoke? Let me see. I think I have some practical examples here that I have. So a patient who smokes daily, I don't think smoking is a problem. My grandmother smoked all the time and lived to 90. So you can ask open-ended question. What do you enjoy about smoking? You want to trigger introspection so that they can think deeply about what they are doing. What do you enjoy about smoking? Have you ever thought about how smoking might affect your long-term health? You mentioned that you want to stay active for your grandchildren. How do you think smoking might impact that? Offer support. I'm always here to talk to you if you ever want to discuss this further. Introspection. So that's what you do at the pre-contemplation. You don't condemn them. And God, you don't say things like you are joking with your health, or you say you are swimming in shark-infested water, like Dr. Festus. You don't say all these kind of things at this stage. You don't condemn them. So you try to facilitate introspection. What do you enjoy about smoking? Have you ever thought about how smoking might affect your long-term health and all those kind of statements? So, contemplation. So, at this phase, they are kind of ambivalent. So, they know that what they are doing is wrong, but they are not ready to change. So, they might tell you things like, um, actually, I know that I am fat, but I find it very difficult to give up the fast food. They have never said any statement about stopping fast food. So that is not anything beyond contemplation. So that is contemplation. They know that what they are doing is wrong, but they are not ready to change. I know that I am a smoker. I know that smoking is bad for my health, but I enjoy the feel of smoking. Contemplation. So in that kind of situation, what you want to do is that you want to expose them to the advantage and disadvantage of that act. That's the first thing. I also want to ask them, like, how ready are you to quit smoking? So if they say that, um, I know that smoking is bad for my health, but I just enjoy that feel of smoking. You now ask them, okay, how ready are you to actually quit smoking? If they tell you, you can ask them on a scale of 1 to 5. They tell you 3. The next thing will be like, why do you say 3? Why not 1? Why not 2? Open-ended, like make them talk to you. Then you can also suggest some options to them. Like, okay, so why don't we start with something small, like you taking like maybe 1 or 2 cigarettes per day? So you can use this statement in both the contemplation stage and the next stage of preparation. Why don't you take 1 or 2 cigarettes per day? Let's start with that. Then you also try to expose them to the pro and the cons. What do you think are the benefits of staying the same, like continue smoking, and you making a change? Because you said it that you actually want like you know that smoking is bad. So what do you think are the benefits of stopping smoking? Rather than staying the same. So that's what you do in the contemplation. Don't forget, pre-contemplation, there's denial. You want to encourage introspection. Like, what do you enjoy about smoking? Have you ever thought about the effect of smoking on your long-term health? Contemplation. They know that what they are doing is bad, but they are not still ready to stop. So you want to like encourage them to stop, by asking them like, how ready are you to stop that action? How ready are you to stop it? And if they give a measure, like, why are you choosing that figure? And you can make some proposals to them. We can work with, taking 1 or 2 cigarettes per day for now. And you can also ask them like the benefit and, the advantage and disadvantage of, quitting. Then the next is now preparation. So somebody will move from contemplation to preparation. They will now tell you something like, yes, I know smoking is bad, but I am ready to stop smoking. I am ready to stop smoking. They have not stopped it. So that's not action. They just tell us that they are ready. So that's preparation. So what do you do in that kind of situation? So like, they are getting ready to change. A patient with alcohol dependence says, I want to cut back on drinking, but I don't know where to start. So you try to encourage them. Don't forget that encouraging, that we say that it will be as if you are whining. It is great that you are thinking about making a change. Let us work together on a plan. You're encouraging them. Then that is now the time to also start setting goals. You know, how about just like you are doing in contemplation too? So how about you start with like 1 drink per day, you know, and that goal is kind of following the SMART criteria, something that is achievable, realistic, time bound. You know, you can see everything is there. 1 week per day, this week, this time, you know, and this is realistic. This is specific. 1 drink, you know. You can also offer like resources, you know, like you can read this, you know, that can also encourage you about the benefits and the of, you know, stopping alcohol. You can learn more about it so that they'll be motivated, you know. Then the next one is now the action. So they have said that they want to cut back on drinking. Now they have now done the goals that we have said to them, that let us reduce by 1 drink. So they are now taking only 1 drink per day. So that is action. That is no longer preparation. They are now doing it. That is action stage. So what you want to do at that point is also to encourage positive reinforcement, just like Dr. Festus taught us in psychiatry that time. Positively reinforce that action. You know, you are doing an amazing job incorporating vegetables into your diet. You are doing a fantastic job, you know, taking only 1 cigarette per day, you know. So you also want to evaluate for challenges. So what has been the, you know, difficult part of this process so far? Because you're already taking 1 cigarette per day. That must be hard. So what has been the, you know, hardest thing for you? Are you still having the craving? You know, you still want to go back? Okay, if the person is telling you, I'm still having the craving, how do you now handle that craving? So how do you handle the craving? You are trying to develop coping strategies. So action, you want to reinforce, encourage them. You know, it's very, very delightful seeing you, you know, reducing your consumption to 1 bottle per day. You know, what has been the challenging part of this process for you so far? How do you handle your craving? Coping strategy. You know, then maintenance. So maintenance, they have quitted for like years. So you still try to evaluate for risk of relapse. So like, when do you feel the strongest urge to drink, to smoke, and how do you deal with it? You know, and you know, just create a plan for them. You know, maybe what they do, maybe that's the time you encourage them to maybe go and watch film or go and play soccer or gist with family and friends, so that they'll be, you know, discouraged. So most of the time they don't ask about maintenance. So once you know your pre-contemplation, your contemplation, preparation, action, you're going to be fine. So don't forget, pre-contemplation, they are denying. They don't even know. So try to ask them, like, what do you even enjoy about smoking? Have you talked about the effect of smoking on your health? Contemplation, they want to stop, but they are not saying anything about stopping. They know it's bad, but they are not saying anything about stopping. Contemplation, they are ambivalent. They are not there, they are not here. We don't know where they are. So expose them to the advantage and disadvantage. Ask them about how ready they are to actually stop. And if they tell you a particular readiness, evaluate why they are picking that level of readiness. You know, preparation, they are not telling you that, okay, I want to stop, but they have not started doing it. So set a goal for them. Set a goal for them. Okay, let's start with this, you know, and then the action, they have now stopped. You know, continue setting the goal. Do like positive reinforcement for that action. For you to stop, you must have done a lot of job. It's not easy. What do you find challenging about the process? How do you cope with the risk of relapsing? All those things. Action, then maintenance. So that's that about you know, behavioral counseling. So let us see. I don't think I have any question here. I don't have any question. So I'm sure we'll be able to tackle any question we see. I'm sure of that. So moving on to patient safety and quality. So this part is 5 to 10% of our exam. We cannot go for our exam and we don't know patient safety. It is too dangerous. It is too dangerous. I cannot overemphasize the importance. So there's something we call safety culture. So in the US, there's an organizational culture that they call safety culture. And what do they mean? They're just trying to shift from blaming individuals for error and be putting all the blame on the system. That is it. So, for example, in the hospital, maybe a house officer mistakenly delivered, no, don't let me use that example. Let's just think of any error that happened. Maybe somebody mistakenly push a drug that's not supposed to push. If somebody push potassium chloride for somebody, and you start blaming the house officer, why do you do that? You revoke your license, and it becomes the talk of the entire hospital. So that is not the safety culture they are trying to encourage in the US. So you want to make sure that you try to provide support, you try to redeem that situation. If it's something you can quickly correct it, inform the patient what have happened, try to educate the person on how the person should have done it, to prevent that from happening, and always encourage the person to also report. So if you have a very good safety culture that you are not blaming the person that was involved, people will be encouraged to even report, incidents, and you'll be able to set up some barriers to actually prevent all those things from happening in the nearest future. But if you are always blaming people that MDCN will revoke your license, you cannot practice medicine ever again. Nobody will want to report any adverse event that happens in the hospital. And you'll be thinking your hospital is running fine, but whereas people are dying, and there's no way you'll be able to set up some measures to prevent all those things from happening again, because people will keep doing it. Just be seeing people are dying and be like, what's happening? Nobody's going to say that this is what I did. So safety culture is very, very important to ameliorate, to avoid, and prevent adverse injury, from happening in the healthcare process. So, what is a PDSA cycle? This should not be here. Actually, it should follow a particular, but we just, go with it as it is in the book. So, the PDSA cycle is more like some steps, right? 4 key process. That means plan, do, study, act. And what it essentially means is just to help you identify some deficiencies in the care system and improve patient safety. So probably maybe they notice that. So I'm just going to be giving practical example. So maybe they notice that the number of infection in the neonatal ward is too high. Everybody's complaining of sepsis there and there. So you need to plan, identify the problem, and identify the need, the outcome that you want to pursue. Okay, they are complaining of what's it called? Infection, sepsis in the neonatal ward. So the plan is, how can we, mitigate this issue? How can we, reduce the number of infection in this neonatal ward? That's the plan. And how do we go about it? That's under the plan. We want to reduce, that's the goal. How do we go about it? That is the plan. Still part of the plan. Now, you have identified a need for quality improvement, right? Now, the next part is now the do. So what are you now going to do? Okay, let us increase the number of washing hand basin or maybe by each patient bedside, you have, washing hand basin. So that is do. Now, one thing about the do is that you do it in a controlled environment and you test its applicability. So you just don't, for example, now, you just don't go to all the neonatal ward and be putting washing hand basin first. No, you can just do it in a simulated environment. Just test it first. Let's just test and see if there's our hypothesis is going to work and correct the problem that we have said in the plan. So let us just, in maybe one word, let's just put washing hand basin and see. Then the next is now study. Study, you now be collecting data. You collect data and be seeing the trend. So you are now collecting data. You are comparing the outcome from what you are getting from what has been happening previously. Is there any change or there's no change? Or we are just whining ourselves? Then the next one is now act. So act is now based on the data you have gathered in your study. If it's something that works, you now act it. That means you are now going to be putting washing hand basin in all the neonatal ward, in the hospital. That is PDSA cycle. That's what they are talking about. Now, under the study, that now brings us to the concept of the Pareto chart and the run chart. Don't be scared about it. It's just big name. Forget about the big name. Nothing there. Pareto chart under the study just means that you are plotting a bar graph with a line. So based on the data you are collecting, let us say that the problem is late arrival in the hospital. So what they will now do is that they will now be collecting data, about the potential causes of late arrival, based on their study, based on the study that they did. Is it traffic? Is it childcare, transportation of the hospital, like bed weather? Some of the doctors were oversleeping. So they plot the problems and they arrange it in terms of the frequencies so that I can have an idea of what to focus on, what to focus on the most to tackle that problem. So that is where you need your Pareto chart. Please don't joke with anything we have been saying since morning up till now. Please don't joke with it. Everything is important. So Pareto chart, that's what you are going to be using. Don't forget what I said about the Pareto chart. So it is listing the problems in terms of the frequencies. What is causing what you want to improve? So let's say in what's it called? NNU now that we are saying infection. It could be maybe they are not washing hands. They will put washing hands here. Topmost frequency. It could be that they are not receiving medication. They will put that one too. So you chart all the problems in the bar and you draw a connecting line to it. So that's your Pareto chart. Now there's also what you call the run chart. So the run chart is there to help you identify the trends. This infection that we are talking about, what is it like in January? Was it like in February? Was it like in March? So you are having an overview of the trend, of that particular problem you are trying to tackle. Do you get? So that's the way it works. So we should know what the run chart is doing, what the Pareto chart is doing, because you don't need to cram anything. All what you are just going to the exam to do just to read. So what are they talking about in this question? Don't panic. What are they talking about? Oh, I will need run chart here. I will need this kind of chart here. And you pick your answer. You are home and dry. It is as simple as that. So let me see. Do I have any question under this? Okay, I don't have any question. I don't have any question. So that's just PDA cycle. You plan. You plan. Please, can we mute our mics? Can we mute our mics?
Because you can be on that place.
Hello, can we mute our mics, please? So sorry. Yeah. So what's it called? Yeah. So PDSA cycle, you plan, you do in a simulated environment. You study the trends, the potential factors that might be responsible for the problem. You plot it on your Pareto chart. You look at the trend that have been happening over the years too, or the month, or the weeks. You plot that on your run chart. Then you act. So once you're seeing that, if you like say the trend on they come down, it seems that this is our stuff that we have implemented is working. So you can now do your acting. That's just PDSA cycle. It's very simple, very simple. So what is a Swiss cheese model? So we don't need all this story. What I just want us to look at is that there is a potential for an adverse event to happen in a hospital. Definitely, a lot of things happen. Hospital, a lot of process happens. Somebody is taking drugs somewhere, somebody is getting injection there, somebody is collecting sample, So that means that there is a risk of error, adverse event happening at every point in time. But at the same time, we have also created some barriers to prevent all those things from happening, right? So let us look at this arrow. This arrow as a problem. Patient dies. That's a problem. That's an adverse event. Patient dies. That's an arrow. But then we have some barrier that can prevent patient from dying. This is so those barriers are called the cheese. This is one cheese. This is another cheese. This is another cheese. This is another cheese. But if there's some holes in the cheese in our barrier, there are loopholes in our barrier, patient will die because the arrow will be able to pass through the loophole and come out, and the patient will die. So once there are deficits, once there are holes in our barrier, in our cheese, adverse event will happen. So what are the potential holes or loopholes that will be happening in our cheese, in our barrier? So the first barrier to prevent a patient from dying is that a physician will take proper history. Make sure that you get the right diagnosis. You know the history of allergy, that the drug the patient should not be on. That is one barrier. But if the physician is impaired, the physician did not take detailed history, that's a hole. So there's a potential risk of the patient dying from anaphylaxis. So the arrow is coming through the barrier. But there's another barrier that is there to prevent it from happening. Yes, the physician fails to take history. Maybe the nurse could have checked the case note from the previous visit, or they could have asked the relative, and they prevent it from happening. That's another barrier. But if the nurse did not also take it, it's a problem. The hole will pass through. The arrow will pass through like that, till nobody eventually picks it and the patient dies. When there are multiple failures in the barrier, the patient will suffer and they will die. So that's what we call the Swiss cheese model. We are always implementing different safeguard measures to prevent adverse events from happening. But failure at each of the barrier, failure at each of the cheese, failure at each of the protective mechanism, once they fail, once there's loophole, the patient will suffer. Adverse event is going to happen. So that is it. So the more the barrier you have, the more the chance of, the less the chance of adverse events happening. So what's it called? The physician takes good history, you pick, the nurse verifies, maybe before the nurse administers, they scan the drug with the barcode to see that it's for the patient. That's another barrier. Or maybe they ask the patient that, are you allergic to this? And the patient tells you yes. So that final barrier might actually be the lifesaver. If there's no hole there, it might actually be the lifesaver and the patient will not die. But if the patient self don't forget that he or she is allergic to drug, and yeah, don't worry, give me, and they gave, that process too is defective and the patient dies at the end. Please, do we understand the simple analogy for this Swiss cheese model? Is it clear to us? Anybody? I can't hear you.
Semi-clear.
Ah?
It's semi-clear.
It's semi-clear.
Yes, it's clear.
Semi-clear. So, like, what we are just trying to say is that there are like barriers to prevent problems from happening to a patient. And what are these problems? Adverse events. So let me give you a very good example. Let me think of something that is really very good that we can work with. Okay, so I'm going to use something we are going to talk about later. We are going to talk about it later. Now, somebody wants to go for surgery. There's something we call the universal rule. We are going to talk about it later. If somebody wants to go for surgery, ideally, you are supposed to talk to the person first. What is your name? What kind of surgery are you going for? What is the site of the surgery? That is a barrier that is preventing a wrong person to be operated, or maybe wrong surgery to be done for a person. Because if you do operation for a wrong person, or you go and do a wrong operation for the right person, that is an adverse event. You don't want that to happen. And how do you go about it? You ask the person, what's your name? What surgery are you coming for? Which side do we operate? That is a barrier. But if you fail to do that, that is a hole in that barrier. So there's a risk of the person suffering an adverse event. So the arrow can pass through. Doctor, you understand what I'm saying?
Yes.
Yes, but there's another barrier that can prevent the adverse event. Even though the person has failed to go and talk to the patient, the person can also be saved by now. Before they go for surgery, they usually do a surgical site marking. They go and mark that area where the person is to be operated on. So even if somebody did not take history and be asking what's your name, but somebody else comes in and mark that site, they could actually save the person from being, from being subjected to wrong surgery. That's another barrier. But if somebody did not mark the site, that's a loophole. The arrow will pass through. The adverse event is the arrow, don't forget. It will pass through again. But there's another barrier that you have put in place, which is what we call timeout. So in some hospitals, they do what we call timeout. That means that before you put a knife on the patient, everybody will do timeout. Oh yeah, nurse will be the leader. Oh yeah, please, before we start anesthesia. Oh yeah, hold on. So, surgeon, oh yeah, hold your knife, please. Yes. So, you see them talking. When we were medical students, then we just sit around. We didn't actually know that was what they were doing. Just be looking at them. You see the nurse putting pen and paper, yeah, asking. So this is Mr. This, yes. So he's here for eniography, right? Eniography, yes. What's it called? The eniography should be on the swelling is on the right? Yes. So they are confirming. That's another barrier they have put in place to prevent an adverse event. So that is your Swiss cheese model. But if they fail to do all these things, so that means that there are some loopholes in all the barriers. So that means that the patient is going to suffer adverse events. Do you understand it now, Doc? Do we get it now?
Yes. You said
So
the adverse effect is the arrow.
that is the arrow. You can see that the arrow can only pass through if there's hole in the barrier.
Yes.
So that's the way it
Thank
works.
you.
You're welcome. So measuring quality outcome. So how do you measure the quality of work they are doing in an hospital? That's the way I look at it. How do you look at the quality of work they are doing in a particular place? Are they doing fine? Or they are? Please don't joke with all these things. These things, you will see them in your exam. Please know it. It has to be at your fingertips. It has to be with you, because step 2 is a fast-paced exam. So you have to know what you know very well. You know it very well, so that as you are seeing it, you are picking confidently. You are not wasting time be thinking. You're only going to be thinking at areas that are technical. But it's very dangerous that something that you already know, you also think you are not wasting time is dangerous. So all these things, they have to be well understood. That's what I'm trying to explain with detail. I'm not just glossing over it. So the quality outcomes, you want to assess, the quality of healthcare service. So it falls under 4 categories: the structural, the process, the outcome, and the balancing. What are they talking about here? The structural, the process, the outcome, and the balancing. Very simple. So the structural is that you are assessing the physical equipment that they have, the resources that they have, the facilities that they have, the number of workers. It can be as simple as the number of doctors. So if they tell you that there's this new teaching hospital that is here and they have like 20 doctors, and there's another hospital that they have 10 doctors, the one with 20 doctors will have a better quality than the one with 10 doctors. Definitely. But what kind of quality outcome is that? Are you measuring? What's that going to be? That's going to be structural, because you are talking about the doctors, the ants that are available. If it's about the resources, there's a hospital that has CT scan. There's another one that is using X-ray. Which one is going to be better? CT scan people. Yes. So they have a better structural outcome than structural quality, than the other place. If which one can I talk about? In another hospital, they are using, what was it called? They are using PET scan. Another hospital, they don't have anything. The part that those ones that have the PET scan, they have a better structural stuff. So you just go and pick structural and you move. It is as simple as that. So what about the process? So the process is now going to be the assessment in terms of quality, the number of people that are actually benefiting from that structure. Okay, we have said that in a hospital there's dialysis machine. What is the number of people that are actually undergoing that dialysis? So if in a place 20 people are undergoing dialysis and a place 10 people undergoing dialysis. So the process outcome or the process quality is better in that place where 20 people are undergoing than where 10 people are undergoing. So that is the assessment of the function of it means that it is functional and they are doing well. Now, moving on to the outcome. So outcome is now what is going to be the impact. So I think I have like, something here to guide us for the outcome. Let me just show you. So let's go back again. Structural. So structural here, the number of nutritionists available for diabetic patients. So this one have 20 and that one have 10. So the one that have 20 is better. That is structural. Number of nutritionists, number of dialysis machine, number of CT scan, right? That is structural. Process, what care is actually being delivered. The percentage of diabetic patients that are now getting screened by these nutritionists that the nutritionists are recommending screening for. What are the number of diabetic patients who now receive HbA1c screening every 3 months? It is high. So that means that the process outcome is good. What about the outcome quality? So what is the average level of the glycated hemoglobin? Yes, nutritionist is there. They are recommending good diets. And 20% or 30% are undergoing screening. But what is now after all this paparazzi now, nutrition is coming to play, what is now the average hemoglobin level? What is now the average glycated hemoglobin level? Is it good? That is the outcome. That is the outcome. Now, the next one is now balancing. So balancing is now the effect of structural on outcome or effect of process on outcome. So if you have nutritionists available and you are checking, you are having a good number of the glycated hemoglobin being measured. What is now the percentage of these diabetic people now coming down with hypoglycemia due to stricter glycemic control? That's going to be the effect of structural on the outcome. Because the structural here is that you're having more nutritionists. And you know that if nutritionists are into play, they'll be telling them, don't eat biscuits, don't eat sugar, don't take that. But is that structural improvement having any effect on the outcome, any bad or good effect? So that's the way you can know is assessing the percentage of people who actually develop hypoglycemia due to stricter glycemic control from the increase in the nutritionist. It's just like saying that, let me give you another example. Structural quality, there's an increase in the number of dialysis machine in the hospital. If they increase dialysis machine in the hospital, that is structural improvement, structural quality improvement. Process, there's now increase in the number of patients that undergo dialysis. There's an increase in the number of patients that undergo dialysis because they have increased structural stuff. So that is a process measure. Very good. The outcome is now going to be, so they are undergoing dialysis now. What is the average level of potassium in this patient? That's an outcome. What is the average level of potassium in this patient? Because definitely, if somebody is undergoing dialysis, you expect potassium to be normal or low. The urea should be normal, creatinine should be normal. That is an outcome, measure, right? Balancing is now going to be effect of the structural on the outcome or process on the outcome. For example, because they have increased dialysis now, and we are now measuring their level of urea and potassium to see if it's okay, which is the outcome. What is now the percentage of people that are now tilting towards hypokalemia? Or what is the percentage of people that are still having elevated urea despite getting dialysis? That's going to be a balancing outcome or balancing measure. Do we understand that analogy? Anybody?
Yes.
Yes.
So that is what you are going to be working with. Which one are they saying?
Can you come again with the balancing part, please?
So balancing part is the effect of the structural on the outcome. The outcome is to measure the level of urea after we have increased dialysis machine. That is the outcome. What we are just measuring. So what is now the level of the urea? Urea is 2.2. Urea is 10 point something. So balancing is now going to be, you are trying to balance, you are trying to check relationship between maybe the structural and the outcome. That, okay, since we have now increased number of people the number of dialysis machine, and that has affected the process because we now have more people undergoing dialysis. So we're not trying to check for the outcome, which is what the urea level. So what is now the percentage of people that are having normal urea compared to people that are having higher or over the roof urea? Do you understand that, doctor? Do you get that?
Yeah, I think I do, but I thought my confusion initially was when you were linking it up with hypokalemia. Is it that we are over dialyzing patients, and you now want to know whether there's an overuse of the dialyzing machine or there's another
Exactly.
problem being caused by the dialyzing machine? That's what
Exactly.
I was thinking.
So what
So I
do
don't
you
know if
think?
that's correct also.
That's correct. That's correct. What will you say about the quality in terms of balancing? If you are measuring potassium and you are getting hypokalemia, are you going to say the quality is good? No. The quality is good because they are over dialyzing. They should not be over dialyzing. Do you get it? So that's why you do the balancing as well.
Yes, I
So
get you.
to
I
see
get you.
if they are over dialyzing or the dialysis normal, when dialysis stuff is normal. That is balancing outcome. That balancing, measure. Very important. That's how best I can explain that. So I think we have some few questions here. Let me see. Okay. This is let me see. Yeah. We have okay. I want to keep this very short as soon as possible because this is rapid review. So a 68-year-old woman is admitted for community-acquired pneumonia. She has CKD and she's prescribed cefepime. However, due to an electronic medical record selection error, the order is placed for ceftazidime instead. The pharmacist, busy processing multiple orders, did not notice the mistake. The nurse administered the medication without cross-checking the patient's allergy list, which indicates a severe cephalosporin allergy. The patient develops anaphylaxis and requires immediate intervention. Which of the following represent the best approach to prevent similar errors in the future? Anybody? Increase the number of pharmacy staff to improve review time. Implement a barcode scanning system for medication administration. Mandate direct physician-pharmacist communication for all antibiotic orders. Require all nurses to double-check medications with another nurse. Educate patients about their medication before administration.
Barcode system.
Barcode system. That is it. Because the only thing that they've not done here is you can't say increase the number of pharmacy staff to improve review time. Why? Because they already said it. The pharmacists have, they are busy processing multiple orders and they don't know they did not notice the mistake. So the only thing that is new here that could have been an extra barrier to stop it would have been if they had a barcode scanning system. That would have stopped it. So increasing the number of pharmacists that would not do much, educating the nurses to duplicate, blah, blah, blah. That's not an extra barrier. The nurses have missed it, in this situation. So the barrier that will have stopped it would have been to implement a barcode scanning system. Okay. Yeah. So moving on to the errors in the healthcare system. So we have to know all the errors, I don't think I have all the errors here. I think this should be true. Oh, I have missed it. Okay, let's go. So, clinicians can have no intention to bring harm to the patient. So, errors can happen. So, let's talk about them one by one without wasting time. Okay, so we have the active error. So, this is the error that happens, at the level of the frontline operator. That is the physician, the nurse, the pharmacist, anybody, the person that interacts directly with that patient. Maybe somebody gives a wrong IV dose, or somebody writes illegible handwriting for the orders. That is the frontline operator. That's not the fault of the system. So that's an active error. It is also known as a sharp end error. Don't forget, sharp end error. In case you see it in your exam, sharp end or active, they mean the same thing. Then the latent error is error that is due to the problems with the system, with the organization, with the hospital, not the fault of the clinician. So that's a latent error or a blunt end error. For example, let me give an example that they are keeping in the hospital. They keep all drugs in the same box. That's an accident waiting to happen. You don't provide what's it called, blood giving set. So they use fluid giving set to transfuse blood. So that's not the problem of the physician. That's the problem. That's error from the system, because system is not the one providing what they need. So look at the question. Look at who is causing the problem. Is it the physician or the system? For example, if somebody in the surgery now mistakenly go and puncture the heart, that's an active error for me, because it's not the system that tells you to go and be puncturing the heart. So latent, blunt end. Never event is error that should never happen. For example, operate on the wrong person, operate on the wrong site. Wrong person, wrong site, and surgery is a never event. It should not happen. Another name for never event is a sentinel event. So if they say sentinel event, it also means never event. They should never happen. Don't operate wrongly. Somebody committing suicide in the hospital is a never event. Hospital is a place where you should be saving lives. So people should always be on the lookout. Somebody committing suicide in the hospital is a never event. It should not happen. Near miss. So near miss is event that could have led to harm but did not, because of the barrier of the Swiss cheese model. The doctor mistakenly prescribed medication that the patient is allergic to because the doctor did not take history. But the nurse was able to cross-check and identify the error. And the nurse eventually did not give that medication. That is a near miss. Because if the patient had been given that medication, the person would have suffered anaphylaxis. That's a near miss. So intervention by somebody or something that led to prevention, but that should not have initially happened. Let me give us another example. And that example is going to be something like, we give the person the wrong, let's say the person is actually allergic to that medication, but we give the person the medication, but the person did not react. The person did not develop anaphylaxis. That's still going to be a near miss. You are not going to say, it's not a near miss now because it was given. Once the patient did not suffer any harm, it's going to be a near miss. So you push 100 milligram of potassium and you are lucky. I don't know how God just saved that person, and the person did not develop arrhythmia. That's going to be a near miss. Very, very important. So medical error, all these things that we are talking about, they are classes of medical error. So which we are going to talk about shortly too. Negligence, so failure to meet expected standard of care, which could lead to direct harm. So you are missing of it. They give you a pathology report like this, that this is cancer. You are still going, you are doing something else again. They give you lab, hyperkalemia, hyper something, and the person is now doesn't know the manual of hyperkalemia, and the patient dies of arrhythmia at the end of the day. That's negligence. Then sentinel event, what's it called? Is otherwise known as, is also known as near miss. So don't forget, sentinel event and near miss, they are the same thing. Something that should not have occurred that now occurred. That is sentinel. Sentinel event is the same thing as never event. Something that should not have ever happened now happens. So negligence, you are not doing your duty as a doctor. This is hyperkalemia. Manage, but you just ignore that. Don't worry, most of them will survive. You to come. Just stop taking banana. Don't worry. Negligence, and patient, develops arrhythmia in the process. So I think let me see. I don't know. Yeah. Okay, so this is a very long stuff we have to go through. So yeah, so let us quickly go through that before I yes. So um so we have talked about the active error, you know, directly. The physician, the nurse are involved, not the system, you know. And sentinel event is also known as never event. Don't do wrong side surgery, wrong person surgery, you know. What was it called? You know, example of latent error, understaffing. Yeah, that's going to be latent error. Implementation of a new equipment without adequate staff training. Yes, that's a failure from the level of the organization. So how do you prevent medical error? Number one, you can do simulation-based training. Very simple. You just put them in a lab, practice. Oh yeah, how do you set IV line so that you're not going to be puncturing, busting people's vein anyhow. This is the way you'll be setting line. You know, how do you do femoral cannulation? You know, so that you're not going to be making people bleed to death. So that is simulation-based training. You know, by doing like hands-on practice, repetition, and all those things. You know, it's very important to learn suturing, urinary catheter insection, BLS, ATLS. So that's simulation-based. That's a way. Another one is human factor engineering, which is important. Human factor engineering is important to help us prevent error from happening. How? And it works by, do I have, I'm so sorry. Oh, I should have numbered this. I forgot to number it. Okay. So human factor engineering is just like examine the interaction between individuals, their work environment, and the tools that they use, and use the information to design a safe and productive system. So you identify risk factor for medical error and you design some system to help optimize performance and reduce the risk of error. So what are the methods under this human factor engineering? First function. Let me give us an example of first function. For example, let's say that the epinephrine. No, don't let me use that example. Let me say that there's just a particular drug, that can be given as infusion. And there's another drug that you cannot give it as infusion. You can only inject it. Now, they have designed the bottle of that one that you can only inject. They have designed it in such a way that you cannot connect it to an infusion set. That is first function. So even if somebody is losing his mind and the person is not, well oriented, and the drug that is supposed to, what's it called, just give by injection, is trying to connect it to the infusion set, it will not enter. That's the first function. It will not enter. That is human factor engineering. So that means that you are relying on the system design more than human judgment, which is very good. That's the best thing. Don't ever put your trust in the human that, don't worry, the doctors will pick it. Any design you are doing, make it at system level, not at human dependence, and be saying that, don't worry. It's just like saying that what's it called? You trust the calculation of human beings, of doctors. They'll be able to calculate the dose of all those pediatric doses easily. Rather than implementing, what's it called? Something in the EMR that can be calculating for them. You are saying, don't worry, they'll be able to calculate it. No. So use system-based, factor more than human, what's it called? Relying on human or something. So that's where the first function comes in. Don't assume that they'll be able to recognize the bottle for injection and the bottle for infusion. No. Make it such a way that the one that is for injection cannot fit into the infusion set. That is first function. Another one is standardization. Standardization means that at every point in time, you are following a standardized protocol, which could be in form of checklist. Okay, have we asked for the name of the patient? Tick it. Have we asked for the site of surgery? Tick it. Have we take informed consent? Tick it. Standardization. We want to do, what's it called? Femoral cannulation. We are following a checklist. It is standardized. If we are doing it in Nigeria, It is the same way they will do it in the US because we are following the same checklist. Have you cleaned the site? Yes. Have you gotten the right equipment? Yes. Do you have a better view? Yes. Have you palpated the artery? Yes. You know that then you have to move your hand 1 centimeter media? Yes. Do you know all those kind of things? Standardization. It's very good. You will not make mistake. Then we also talk about the universal protocol. What's it called? So first function is under the human factor engineering. Standardization is standing separate. That should be number 3. So after simulation-based training, we have human factor engineering like first functions. Then we now have standardization number 3. Then number 4 is going to be like, universal protocol. So universal protocol, just like I've said, you want to, for if according to, is a 3-step something that is defined by the Joint Commission. Don't worry about that. Just to prevent wrong site, wrong procedure, and the wrong person surgery. You don't want to operate on the left instead of the right. You don't want to go and amputate toe instead of doing eniography, wrong procedure. You don't want to go and operate Dr. Lagbaja instead of operating Dr. Tamedo. Very important. So how do you go about that? The first 2 steps is to do a pre-procedural verification of the patient identity, the surgical site, and the surgical procedure. What is your name? Where are we operating? What are we doing for you? The next thing is to do a surgical site marking. You mark the area. The third one that they're always silent about before you do your timeout is you also have to ask the question from the patient, especially in the theater, before you deliver anesthesia. You want to ask the patient, sir, what is your name again? What are we doing for you? Where are we operating? That's the third step. Then the last is now going to be your timeout. They have administered anesthesia, meaning that the patient is no longer with us. The patient has done his own part. It's now in your hands, trusting us as doctors. Then we will now do timeout. Before the surgeon puts the knife, the nurse will now try to do timeout. What is the name of this patient? What is the procedure to be done? Which site is to be operated on, to prevent any adverse event from happening. And the adverse event that's going to happen here, if it's successful, what adverse event will have happened? Anybody? What will we call the adverse event? A what?
Never miss.
Never miss. Or never event. Don't say never, it's not never miss. Never event or sentinel event. But the never is there. The never is there. Never event or sentinel event. We have near miss, not never miss, near miss. So it will have been a never event or sentinel event. Yes. So, simplification is another one. So if you can simplify the process, go for it. That's going to be option 5, simplification. So what are they talking about here? Use ordering laboratory test, like order it electronically using the computerized provider order entry. So you just input your ordering. That one is very good for someone like us because some of us, we don't have good writing. So that by the time you start writing buspirone, they might think is bupipione that they have written. So, but with computerized provider order entry, that mistake is not going to happen. Or for example, somebody wants to write 10 milligram. Maybe there's now mistaken. No, somebody wrote 1.0 milligram, and the pharmacist saw it as 10 milligram, and they go and overdose the patient. So in the in the computerized provider order entry, there's nothing like point. You don't put in point. It is not accepted. So you cannot make that mistake. Simplification. And also there's a clinical decision support system in which by the time you go and be calculating pediatric dose and you are calculating something that can kill the child, the computer will alert you immediately that doctor, check. Confirm. Alarm is going to ring. So that's your clinical decision support system. Or maybe a patient is already on some medications. You don't know. And you go and add something else. Probably the patient is on warfarin. You're not going to add maybe heparin again. Please on Clexane. The clinical decision support system is going to alert you that this guy's already on this. Be careful. Simplification to prevent error. Then the last is usability testing. So this one is very concerned with ergonometrics, like ergonomics rather, not ergonomics, so that what's it called? The healthcare personnel, they are going to be trained. They are going to do some training on how to use some of the equipment so that they can identify potential challenges that comes with the use of the equipment. For example, maybe they go in and they are trained on how to be using some particular sutures. Some surgeons, in the process of doing their simulation in the labs, they'll be like, this suture, this one, they hard to penetrate the skin. Oh, it's not entering. The needle is not entering very well. It's blunt. Or the way I'm holding the forceps, it's painful. Like it's not very comfortable, ergonomic. So they can only identify that through usability testing. But if they did not do usability testing and they just buy new product and just dispatch it, distribute this one to pediatric ward, neurosurgery, take, and they start using it and it's not comfortable, they can start making mistakes. Usability testing, very important. So don't forget them. Stimulation-based training, human factor engineering, which includes like first functions, standardization, using checklist, universal protocol. Don't forget, always ask, what's the name? You do it like that till it knives the patient. Simplification, using computerized provider order entry, a clinical decision system, and usability testing. So how do you prevent medical errors, medication errors now? So safe prescription writing. If you don't have electronic prescription, if you want to write it safely. Write the drug name in full. Nitrofurantoin. Don't say NF or NFR or Labet. Like some people like Labet. Labet alone. Put in the dose. 100 milligram. Put in the route orally, IV, intravenously. Don't say IV, intravenously, orally. Frequency. Don't say BD. Don't say TDS. No. Twice a day. Spell it out for 5 days. That's a good way to write it. So they can write you a prescription and tell you that which one is wrong, so you know what to pick. You put in the indication. You don't abbreviate, and if there is a facility for computerized physician order entry, use it. So it can help prevent error from poor handwriting and ambiguous abbreviation. Sometimes you might need to use tall man lettering if you're writing prescription. For example, somebody that wants to write bupropion, and buspirone, they look very similar. So you are going to highlight where they are, different. You can highlight this bupri. You put it in capital letter. You can now write this one in short, in small letter, pion, so that they will know that this is bupropion and not buspirone. Very, very important. Tallman lettering for medications are very similar. Dobutamine and dopamine. Put it out. Dobu. It is dobu, not dopa. Don't make that mistake. Then, aside from safe prescription writing, another one is medication reconciliation. Cannot go for exam, you don't know medication reconciliation. It's just a process of, performing, like, evaluating the drugs the patient is on, during transition of care. You are admitting, you are doing medication reconciliation, you are transferring from neonatal ward to children emergency, or from children emergency to pediatric, any ward. You are doing medication reconciliation. You are discharging home, you are doing medication reconciliation. What are you doing? You are just looking at the list of drugs the patient is on. You are looking at it. Okay, patient on the drug, this. And I want to add this. Is there any potential drug-drug interaction? Is there any dosing error in any of the drugs that the patient is on? Is there any duplication? Is there any omission? You check at each point. Don't say that, I'm running at what? Sorry, I'm so sorry about that. I've forgotten some of our know Yoruba. The renal people have come. They have checked the drug. Don't worry. Respi, you just see. Don't know. If Respi 2, they are coming, they are going to check. do medication reconciliation. If cardio is coming, they must do it. They must do it. Medication reconciliation, very, very important. So we have talked about what you are going to save. If you are doing medication reconciliation, blah blah, all those things. Confirm the medication that the patient is on. Check any previous medication that the patient, is currently using. Identify any discrepancy, and that. Then also make sure that don't forget to, when transferring to discharging, don't forget to look back at the whole medication list. Very important too. Don't joke with all these things. So patient education on medication. Always educate them on their medication, because limited literacy is associated with increased risk of medication error. So try to educate them about their drugs. This is what you are using. This is what it's going to do. This one is for hypertension. This one is for diabetes. This one again. Then tell them to explain it to you. This is the way you are going to be using this one in the morning. This one you are going to be using this one in the afternoon. Teach back method. Don't forget, we have said it. Teach back method. Use that one in the afternoon. Use that one in the night. Evaluate for the understanding of by asking the patient, to prevent error. Teach back method. And also ensure that they can reach you when they have any questions. And consider offering administration aids by putting in blister packs. Blister packs, pill boxes, very important. So it will be easy to use. You see the blister pack, they have named it Monday, Tuesday, Wednesday, Thursday. They will just be punching it. Take this one on Monday, take one on Friday. Very easy. Now, another problem is communication error. How do we prevent communication error? Especially handing over, when they are handing over, the way we hand over, sometimes just do it rush or chaply. We admitted like 10 patients, this one is there, you are just confused. So, but you have to do it properly. Communicate as clearly as possible and start with the most important, like the bad patient. Those are the ones you are going to start with. And you're just giving concise, relevant information. You're not going to be presenting the entire history because they will not be able to absorb everything. So emphasize the pertinent information of the patient. This patient is taking digoxin. So the patient cannot be on digoxin and you are starting with, please administer vitamin C. Ensure that the patient is taking the Martinix. You are clearly joking. So emphasize the important things. This patient is taking digoxin. We are monitoring the trough level of the digoxin. Watch out for any side effect, blah, blah, blah. Talk about the bad ones and the critical ones first. Avoid medical abbreviations. If it's possible for you to provide like written rather than verbal, do it. Because you can document, you can easily go back to it. Verbal, they can forget. They'll talk, what did he say? If like say just say we just give him this. I think that's what he said. You're just gonna do what you are not supposed to do. But if it's written, you can easily go back to it and confirm. So don't forget the closed loop communication. Give that patient 20 milligram furosemide. You said 20 milligram furosemide, yes? Yes. Closed loop communication. Very important. For critically written results. So a patient result is back. Don't send email to the other physician. Oh yeah, from radiology, we send email to your physician. The physician will have gotten it. You don't do that. Especially for critical patients. You call over the phone because you are sure that the patient has received it. The doctor has received it if you call. You are not going to be sending email. What if the person did not see the email? What if the email enters spam and they don't know? It's not in inbox. And patient is dying. So follow up by calling to confirm, that the result has been gotten and the result is understood. Very important stuff. Anticipate transition of care errors and proactively intervene, handoff related error and all those things. So that's it. So use standardized handoff tools. Everything, you see, once you say something standardized, look at it well because it's possible to be the answer. So you'll be asking yourself, have we talked about the critical patient? Have we talked about the number of patients? Have we emphasized the important ones? All those things. Checklist, standardized handoff tools. They don't need us to go and be cramming what is in the tools. Just know that you have to use standardized handoff tools. How do you manage medical errors? So we have to respond to the problem immediately. So we have given a patient wrong drug. Maybe we give digoxin instead of giving what's it called? Dobutamine. They went to go and give digoxin. Quickly go and arrange for your digabind. Neutralize it. You know, that's when you start blaming. What about patient? You don't kill him. Yeah. No. You quickly do your rescue immediately and you institute corrective measure to stabilize and prevent harm, and you communicate the adverse event to the patient. This is very, very important. You don't hide that information at all. You tell the patient, you know, I'm afraid, we mistakenly pushed in this. You have to tell the patient. Don't go and hide it from the patient. Patient autonomy, if an error has occurred, don't forget safety culture. You have to disclose. Fill an incident report form. Very important stuff. Medical error disclosure. Don't forget. Don't forget. So report it so that they can use the information to also process on ways to improve the system to avoid all those things happening again. Very important stuff. Please don't forget all these things we are talking about. Yeah. So disclose the error to the patient. If necessary, tell the administration or the supervisor. Don't say that now my guy now. Don't worry, guy, we go cover. Don't cover because you might be in trouble. Don't cover. Report. You encourage the person to report. If the person doesn't report, maybe you go and report. Just make sure that it gets to the administration. Fill the incident report form. State what led to the error. Inform the patient. You will have instituted corrective steps. That's the first thing. Save that patient first before you start reporting. And express personal regret and apologize, and allow for ample time for question. And so for a suspected error by a colleague, so this one is suspected, not that you are sure. So we can discuss the circumstance of the error with the colleague, try to talk to them, so encourage the person to also report to the standardized protocol. If there's a disagreement, whether an error occurred or whether it needs to be disclosed, you can discuss with the ethics committee or the medical director to know the best next step. So don't forget, the patient must be informed and you have to fill the incident reporting form. Very important. Very, very important. Okay, so let's just quickly round up for today. There's health worker burnout and fatigue. Of course, doctors, they work a lot of time. They can get let's just solve this. I think I have is it one? No. It's more than one. Okay. 2 days after undergoing an elective cholecystectomy, a 48-year-old woman developed a fever and worsening abdominal pain. The surgery and the immediate post-operative course was uncomplicated. A plain X-ray of the abdomen shows surgical forceps within the abdominal cavity. The incident is best described as which of the following? Anybody?
It's a never event.
Never event. Never event. I thought we had more, but okay. These are the bias here. Okay. I think we quickly need to talk about the biases. So burnout is a very serious problem. It happens, work long hours, you become so stressed. That could be affecting the cognition and the like. So it could lead to cognitive impairment and it could lead to medical errors. So, and this is due to excessive stress, prolonged stress, prolonged calls and the like. So how do you minimize burnout? Set clear and consistent goals for the staffs. Provide training to increase coping strategies, role effectiveness and nurture conflict resolution strategy. Encourage support groups, organize workloads and working time with regular breaks and flexible schedules. Provide accommodation for healthcare workers during emergency operation with good access to food services, sanitary facilities, and adequate educational opportunities. These are just things you can think through. So, what's the effect of burnout? So they can lead to some form of bias too. And let us look at this bias that we have. So So we have anchoring bias. So we have to know our bias. Very, very important stuff. The anchoring bias is the tendency to inappropriately rely on initial perception or a piece of information, which later hinders judgment when new information becomes available. A very good example is if somebody comes in now and the person says he's coughing, he's having chest pain, he's having chest tightness, wheezing. Okay, somebody like me will have been thinking this is asthma. We now proceed. We do the pulmonary function test. It is normal. What was going on? Although it might still be normal in between attacks, fine. Maybe you do the bronchial provocative test with histamine and all those things. Nothing is there. It's not like it to be asthma. Or you listen to the chest, S3. Leg is swollen. This now and leg is swollen. S3 sounds. You measure BMP is elevated. This is in keeping with heart failure now. Probably the wheezing is from cardiac wheezing, but because the person has already had that initial diagnosis in mind that once I see cough, wheezing, chest tightness, I just pick asthma. So that's going to be an anchoring bias. Even though there's new evidence to the contrary, the person is still holding on to that initial diagnosis. That is an anchoring bias. Availability bias would be bias based on memory, based on things that you have been seeing recently. For example, during the COVID time, there's a lot of availability bias that will be happening at that time. Seriously, because everybody, you are coughing, chest pain, coughing, anything, COVID. Somebody will come with asthma, you will not know. Somebody will come with pneumonia, they will not know. Because that was what was trending at that point. That was what was available at that point. So everybody will just be making the premature diagnosis of COVID. That's availability bias. Framing bias would be the way the information was presented. So let me give us an example. For example, let's say that a sales rep, all these people that used to come to the doctor to be able to market drug, they can come and say that, you see this drug, this sacubitril, this drug, 90% of people that take this drug, they survive. Whereas in real sense, the drug reduced mortality by 10%. They are not going to be saying that it reduced mortality by 10% because it doesn't sound good. But when they say that 90% of people, that were tested on this drug, they survived. So that sounds better. That's the framing, the way the information was presented. Another one would be that the order of the symptoms. So they listed all the symptoms that were in keeping with maybe a particular diagnosis, and go and put another symptom that could have changed the diagnosis. They go and put that one at the bottom. So maybe you are going through somebody's case note, you are just seeing bone pain, bone pain, SS, bone pain, hematuria, this is like sickle cell stuff now. But maybe there's something else. Maybe the person is not having hepatosplenomegaly, which could be maybe gotchas or something, but you not pick it. Maybe they put that one back. Although hepatosplenomegaly too can happen, maybe sequestration crisis, but but we get what I'm saying. Maybe they now do the biopsy, we're seeing foam, macrophage, and all those things that was in keeping with gotcha, but they did not still pick it. So that's going to be like a framing because of the way that information was arranged. So visceral bias is going to be you basing your clinical decision based on your perception of the patient. This guy that is using marijuana, this guy going to choke himself with a lot of needles. It's possible that this guy is having hepatitis C. You just have some negative feeling. It's possible that this guy will have hepatitis C where he's choking himself. That's a visceral bias based on your own feeling of the patient. Visceral, your feeling. Ascertainment. So you tend to base your decision based on preset assumption. A very good example is going to be like gender bias. It falls under ascertainment. And I'm going to give us a very good example. Let's say that, during our cardio, they usually say that, um, uh, although don't let me use that example, let me use another one. Let me say that still on cardio, women now, they what's it called? They have a very low chance of having hair mark because of the protective effect of estrogen. Now, a woman, 30-year-old woman, now that's still menstruating, that has, that's not menopausal, estrogen effect is still there. Now comes in with chest pain, sweating, refer pain to the jaw. That looks like classic MI. You are now saying, you have read it in the books. Preset assumption. Women rarely have MI because of estrogen. And you are not making the diagnosis of MI. So that's going to be an ascertainment bias. Or maybe because they've told us that we don't do screening for abdominal aortic aneurysm in women, even though they are smoking. But maybe they now did this ultrasound, they are seeing the aneurysm, but you are saying that, this is a woman. It's not possible for him to have an aneurysm. Gender bias, ascertainment bias. So gender bias falls under ascertainment bias. I'm so sorry about this. So sorry, let me open it one more time. Okay. Information bias. So you are just collecting information more than necessary. Okay. So when you now went to that place, what did you now do? Okay, so when you now go back home, what happened? Okay, you are just asking information that is irrelevant. Information bias. Aggregate bias. So you are assuming that clinical guidelines do not apply to an individual patient for whatever reason. I don't know the problem that the doctor have. You're just saying that the aggregated data from clinical study does not apply to you. Aggregate bias. So commission bias is very common to prefer, which is tendency to prefer action over inaction. Commission bias. When you do something, you commission. When you omit, you don't do anything. So tendency to prefer action over inaction is a commission bias. So let me give practical example. So somebody comes in with asthma. The person is just having cough, chest tightening, all those things. No fever. They do the white blood cell count, normal, no leukocytosis, but you have like, most of the time, bacteria provokes all this asthma now. Let me just give him antibiotic. You just go and give antibiotics because you had tendency to prefer action over inaction. That's a commission bias. Omission bias is when you're supposed to do something, you don't now do it. You're supposed to, when somebody comes with sickle cell crisis, but because you are like, this person is well hydrated now, it doesn't look as if he needs fluid. Don't let me give fluid. That's the omission bias. Tendency to prefer inaction over action. So all what you just need to know is just the understanding. Forget about the way they will paint it. Once you read it, you know what they are talking about. You pick your answer, you move confidently. Then the last one is premature closure. People that like doing spot diagnosis, this is their own bias. Premature closure. Okay, so tell me the history. This patient presented to us 10 days ago with chest pain, difficulty in breathing, leg swelling. Forget about P. No, next one, that is premature closure. So, very, very important to understand all those things. I think there's still some other ones here. Yeah, I've talked about premature closure. Overconfidence bias. So they have the tendency that their skills and knowledge are greater than in reality. Overconfidence bias. Zebra retreat. So this one is still stands to reason in a way. So we disregard the potential diagnosis because of reality. Like I used to remember when we were in medical school, they used to tell us common things occur commonly. What are the causes of kidney? Everybody wants to be moving stuff. They are making diagnosis of, you are saying Guillain-Barré, you are saying or maybe all these epilepsy, you are saying they're not gassed out. You're not talking about common things. So common things occur commonly, but sometimes it might not work. So anybody that is doing common things occur commonly too can be obeying zebra retreat bias. Maybe because zebras are very rare animals to find. So when you now retreat, because you saw a zebra, because you feel that it's going to be rare, that's going to be a zebra retreat bias. So a clinician disregards the potential diagnosis because of its rarity, even though there's enough evidence that supports that diagnosis. So that's zebra retreat. Conjunction fallacy. So this is a false assumption that the probability of a joint event happening is greater than the probability of the event happening individually. This might be difficult to remember, but I will give us an example that will always make it stick in our mind. So let's just say that somebody comes in with same example as what I've been saying before. Somebody comes in with chest pain, sudden onset chest pain, chest pain, cough. The pain is said to refer to the jaw, right? So like, this is MI now. Person is now having leg swelling. So we're now saying this is MI plus P. So the person is saying that this person has a very high chance of having two diagnoses occurring simultaneously, MI plus PE, rather than saying either MI or PE. So that is going to be a conjunction fallacy. We are having a false assumption that the probability of a joint event, MI plus PE, is higher than this stuff happening individually. So how do you analyze medical error? So this is where we are going to wrap it up. We just solve the questions and we just call it a day. I'll continue tomorrow by God's grace. So analyzing medical error. There are different ways we analyze medical error. So the three common ones include root cause analysis. You can't go for your exam, you don't know root cause analysis, you don't know FEMA is wrong. You have to know them. Root cause analysis, failure mode and effect analysis, morbidity and mortality review. So root cause analysis, you are just doing a retrospective study. The deed has been done. You are just trying to look backwards. That patient that died from that house officer, what actually happened? Why did it happen? And there are different ways by which you do your root cause analysis. You can use the 5 whys approach. You can do the Ishikawa diagram or the fishbone diagram. So anyone you see in the exam is the same thing. Fishbone or Ishikawa diagram. The cause effect diagrams or the process maps. So the 5 whys is going to be you asking yourself why 5 times. Why did the patient receive the wrong medication? So the patient received the wrong medication. That is the problem. That's the medical error. You ask, why did the patient receive the wrong medication? The nurse did not complete patient identification. Why was the patient identification not complete? The patient did not have a wristband. Why did the patient not have a wristband? The wristband was removed for a procedure. Why was this wristband not replaced? The wristband printer was out of service. Why was the printer out of service? The IT staff did not have resources to fix the printer. So that's the root cause. You can get to the root of the matter. So it's because when you treat the root cause, that's where you can prevent the cascade from happening. 5 whys. Another approach is you draw your fishbone diagram. So this is what the fishbone diagram looks like. You can just put fishbone diagram in the exam and just tell you what is this. So if you look at the central portion, this is a problem that they are trying to tackle. Long waiting time. That is the error that is happening. There always long waiting time in our hospital. So the fish are some things, what we have here, the environment, methods, equipment, and people, that talks about the potential category of problems that could be responsible for the problem. The potential category of factors that is responsible for the problem. So it's either the problem with the method, the environment, equipment, or the people. You now start looking at them one by one. Don't forget, you are doing a retrospective study. That what is the cause of this long waiting time? Is it a problem with the method? You now start writing out your methods. What are the potential things that can happen with the method? Is it that we have too much paperwork? So if you look at, this is it. So now after you have identified the factor category, you now identify the primary factors associated with the category. Now, if you look at this method now here, this is the method. You see that there's a straight vertical line coming down. So that is talking about too much paperwork. So, yeah, no, this one was not labeled, but yeah, let me say too much paperwork. That is a problem in the method. They have too much paperwork. Now, there's now secondary factors. I share with the primary factors. So they can label this in your exam. So this is going to be primary. This one that is branching out from it are going to be the secondary. So why are they having too much paperwork? Is it that there's bureaucracy or there's disorganized file or something? Let us look at another one that is much more easier and relating to medicine. So if you look at this, people is a factor. Now, what can happen to people? The primary problems, unexpected patients. So that's why we're having long waiting time. People or patient jumping queue. That's why you can have a problem, the primary problem. Now, what is the secondary problem that can be responsible for patient jumping queue? That's the branching. Secondary problem. They have original appointment missed. Oh, so because they have original appointment missed, they are now coming to the hospital at the wrong time, trying to jump queue. Thugs. Now, unexpected patients. Why do we have unexpected patients? Because of incorrect referrals. That's the secondary problem. Like that. That's how you keep writing it until you find the root cause of the problem. Fishbone diagram or Ishikawa diagram. It is as simple as that. Then we have the process map. Process map is just that you just highlight the workflow and see where the problem is happening. Now the problem is that what did I state as the problem here? The error is that a large number of patients never come for follow-up appointments. Okay, so how do we want to identify the cause of this problem? We are going to do a root cause analysis, but we are going to be using the process map. So we start from the process. How do we even start? So if they come for anticoagulant blood testing, number one, they are going to arrive at the clinic. The patient information is processed during check-in. That's the next thing. Sample is taken. That's the next. INR test is performed. Patient is given results. Clinic schedule a follow-up appointment with the patient. So the error is now that a large number of patients never come for follow-up. That's the error that we are getting. So, I'm so sorry. Okay, that's the error we are getting. Now, we have to do a root cause analysis to see what phase is actually the problem coming from. So, example, patient email database is faulty and the patient received neither the results nor their invitation to even schedule follow-up. So that means that the problem is that the clinic schedule a follow-up appointment. Are they actually doing it? So you look at it one by one. Okay, patient arrive at the clinic. Okay, they come for the clinic. Is everything okay when they come for the clinic? Yes, you tick that one. Patient information is processed. Do they actually process the information when they check in? Yes, they do. Okay, that's fine. They take their blood sample, right? Yes. INR test is performed. Yes. Patients are giving their result. Are they giving their result? Because if they are not giving their result too, they will not come for follow-up. They will be vexing that they don't even give us result here. And we are going to another place, Joe. Do they give them their result? Yes. Okay. The clinic schedules a follow-up appointment with the patient. Do they actually schedule follow-up? No. That is where the problem is. Process mapping. Very, very important. So these are the things you can use to determine the cause of error in the medical setting. If you are doing your root cause analysis, you know that it is problem that has happened. You are not trying to look at what happened. By using the 5 whys, the Ishikawa diagram or fishbowl diagram, and your process mapping. Why for failure mode and effect analysis? This one is actually for problem that you anticipate to happen. Prospective analysis. So what are you doing? You want to create a new surgical ward. You now start looking. Fine, this is a good idea. But what are the potential errors that can happen? What are the failure modes? What are the causes for this failure? What are the failure causes? What is going to be the result or the effect of this failure? What is the failure effect? So let us look at, I think I have like a summarized explanation. Oh, why is this thing not clicking? Oh, I think I've made. Okay, let's just proceed. Let's proceed. So this is just more like anticipation. So this process helps you build redundancies that act as safety net to trap errors. so that you can use inductive reasoning to identify all the possible ways a system might fail, and you prioritize them by probability of occurrence and impact of patients. So we are introducing a new device that we have not used before. What are the potential things that can happen with this device? Can patients get killed? Can patients get injured? Can there be difficulty in the physicians handling it? That's failure mode. So the failure causes will be that, is it because it's new? Is it because they have not been subjected to any training? Is it because, they just don't like it and they are trying to, act that they are not in support? Failure effect, failure causes. And the failure effect will now be, so if patient dies, of course, if patients are injured, they can die. If many people are dying, nobody will come to our hospital again. That's failure. So that is your failure mode and effect analysis, so that you can now draw in potential solutions. Okay, now let us actually do training first. Let us do simulation-based training or do usability testing before we introduce this device, so that any problem that can happen, we'll have picked it and we'll correct it. Let us try to organize seminars to actually encourage our doctors to actually be using this device, so that, because it's going to be for their own best, for their own comfort, and for the best interest of the patient. Failure mode and effect analysis. It is as simple as that. So with all these things, you can prevent medical errors from happening. Then the last one is not going to be M&M. We all know M&M. Our consultant will just sit down, they analyze with the resident, the medical students. They look at people that died. Oh yeah, this patient that died, present. What happened? Or patient that falls sick. What actually happened? What did you do? How did you do it? What now happened? So it is not a meeting for criticism. No. It is actually to just look at the process, how it, what actually happened, what went wrong, so that you can, provide better solutions to prevent all those things from happening again. So let's look at this question quickly. Okay. So yeah. So a 72-year-old woman is admitted to the hospital for pneumonia. Her history includes CKD and hypertension. On hospital day 3, her condition worsens, requiring admission to the ICU. She started on Vico for sepsis. 12 hours later, she developed sudden onset confusion, oliguria, and sharp rise in creatinine. Despite immediate discontinuation of the nephrotoxic medication and aggressive fluid resuscitation, she progressed to AKI regarding dialysis. A root cause analysis is conducted. The investigation finds the initial antibiotic order did not include a renal dose adjustment, leading to toxic accumulation. The EMR default setting did not alert the physician about CKD-related dosing adjustments. Pharmacy verification was done due to high workload, so the error was not flagged in time. The nurse, unfamiliar with the renal dosing protocol, did not question the dose before administration. Which of following is the most appropriate systemic improvement to prevent similar errors? Anybody? Anybody?
B.
Beautiful boy.
Which one? Which one are we picking?
Implement an automated EMR system, alert system.
Implement an automated EMR alert system for renal dosing adjustment. That is it. Require all physicians to manually enter. In fact, that's where you now be causing problem. Increase number of pharmacies available for medication. Now, pharmacies are there. What are they even now doing? They are still missing it. So they cannot take care of the problem. Conduct a mandatory renal dosing education. So what tells you, what makes you sure that if we still educate them, they will still not make the error because you are depending on human beings? No. So implement automated. That's it. Is B. Very correct. Thank you. So a 55-year-old man is scheduled for a laparoscopic cholecystectomy. The hospital has recently introduced a robotic surgical system to assist with minimally invasive procedures. Before implementing the system hospital worldwide, a team of surgeon, anesthesia people, nurses, and biomedical engineers meet to analyze potential safety risks before force use. The team identified the following risks: potential robotic arm malfunction, delaying. Please, what are they doing? Anybody? What is this? My people. Oh yeah, oh, this one is
Failure mode.
failure mode and
Failure
effect
mode
analysis.
analysis.
Failure mode and effect analysis. There's no need to do a EOJ, like the professor will say. No need to do a EOJ. You already know what you are picking. You understand the question, you pick your answer straight up. So this is the last one. The head of the surgical department at a university hospital notices that the rate of near misses related to the patient identification process prior to the surgery has increased over the past 1 year. She decides to implement a monthly recurring meeting in which selected cases are presented and discussed. The aim of the meeting is to identify the individual actions that led to the errors by providing a non-punitive space for self-reflection and to determine the strategies to prevent their recurrence. Both surgeons and surgical trainees, residents and students are asked to attend the meeting. Which of following is the most accurate description of the activity initiated by the head of department?
So root cause analysis.
M&S. Failure mode and effect.
No, somebody is saying failure mode. Somebody is saying failure mode, though. But we said they said the problem has occurred. Is it going to be?
This is
Sorry,
a root cause analysis.
sorry. They
Or
said surgeons, surgical training, medical students are coming to discuss case. That's them and
M&S.
yeah. Somebody was saying failure mode. It's not failure mode, though. Please. Failure mode is not for something that have occurred. You are thinking ahead for failure perspective. What are the potential that can occur? But if something that have occurred, it's going to be M&M, or root cause analysis. And we've talked about root cause analysis, fishbone diagram, process mapping, cause and effect, blah blah. That's what we are going to be using. I think we have one more stuff here. A 52-year-old man comes to the physician because of 3 weeks history of cough and hoarseness. He reports that the cause is worse when he lies down after lunch. Temperature is 37.5. The vitals are normal. The physician has recently been seeing several patients with common cold, and the diagnosis of upper respiratory tract infection comes to mind. The physician fails to consider the diagnosis of GERD, which the patient is later found to have. Which of the following describe the cognitive bias that the physician had? Anybody?
Availability bias.
Availability bias. Very, very correct. Thank you. So a 29-year-old man comes to the emergency department 2 hours after episode of shortness of breath, chest pain, palpitation, and sweating. He did not cough blood during this episode. Symptoms resolved spontaneously after 15 minutes. He had no history of deep vein thrombosis or PE. Medical history is stigma or tobacco use and panic disorder, for which the patient takes sertraline. So, vitals is normal. There's no leg swelling or edema. ECG is normal. Emergency room physician determines that the patient has a very low probability of having PE, but decides to order D-dimer test to evaluate for PE. The physician decision was most likely subject to which of any type of bias? Anybody?
Commission bias.
Commission bias. So, a 68-year-old man comes to the physician because of chest pain that began after he lifted a box 1 hour ago. On several previous visits, the physician has diagnosed himself with costochondritis. He has hypertension and type 2 DM, blah, 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 blah. Let's see. There is mild tenderness to palpation on the 4th to 6th rib. The physician diagnoses costochondritis, prescribes ibuprofen, and sends the patient home. 2 hours later, the patient is brought to the emergency department of chest pain related to left shoulder, dyspnea, and nausea, and ECG shows feature of STEMI. Which of following is the most likely cause of this medical error?
Premature closure.
Premature closure. That's very good. I think we are home and try. We respect all this bias. So once you see any question on medical error, patient, so it means our patient safety now is 100. I'm just going to add some little things, to what we are going to talk about tomorrow with respect to the patient safety. And I think we should be home and try. Do we have any question? Anybody with any questions so far? Okay. So in the absence of question, I think we'll call it a day. I will continue from here tomorrow by God's grace. All right. Bye bye, everyone. Bye.
Thank you.
Bye.